welcome everyone. Thank you, commissioners. Thank you to our consultant team and all of the members of the public who are joining our September meeting, September 23rd meeting of the Healthy California for All Commission. Before I get into my opening comments, I wanted to turn it back to Karen. If you wouldn't mind going over sort of the ground rules that everybody's become familiar with, how we're going to get through the meeting. And then at the same time, do you mind doing quick roll of the commissioners? Thank you.
Happy to do that. Yes, of course. Welcome. So today's meeting is being recorded. Commissioners, you have the ability to mute and unmute and use your cameras for video. We appreciate that you have yours on right now. Please do remember to mute yourselves when you're not speaking to reduce background noise. And if you would like to speak, if you could please use the raise hand feature in Zoom, which is at the bottom of your Zoom screen. You'll see an icon called reactions. Click on that and you'll see a raise hand button. Members of the public, welcome. You are in listen mode only, but you will have a chance to provide comment during the public comment period of today's meeting. We will announce that before we begin that comment period. And at that time, we will open up the chat feature and invite you to provide written comment in that manner. You may also provide written comment by emailing healthyca@chhs.ca.gov. And we will also be inviting verbal comment at that time, and we'll provide instruction on how to go about getting in the queue for that. All forms of public comment during the meeting will be part of the public record. We also have the live transcript mode enabled at the bottom of your screen. If you click on live transcript, you'll have closed captioning during the meeting. All right, moving to roll call of our commissioners. When I call your name, if you could just unmute and say hello, that'd be lovely. Secretary Galley.
Hello, good afternoon.
Carmen Komsky.
Hi, everyone. Good afternoon.
Jenny Chin Hansen.
Good afternoon. Thank you.
Bill Shao.
Hello, everyone.
Bob Ross.
Here, good afternoon.
Richard Scheffler.
Afternoon. Hello, everyone.
Sandra Hernandez.
Present here. Nice to see everybody.
Andy Schneider.
Hello, everyone.
Sarah Flox.
Here. Hello, everyone.
Kara Desert.
Good afternoon, everyone.
Antonia Hernandez.
Buenas tardes.
Anthony Wright.
Good afternoon, everyone.
Jim Wood.
Good afternoon, everyone.
Michelle Bass.
Nice to be here.
Peter Lee.
Present.
Don Molds.
Hello.
And has Senator Pan been able to join us yet?
He has not. He texted me back, said he's running late. We should keep moving, and I'll catch him up later if need be.
Thank you, of course. And Commissioner Rupa Maria, we understand, will join us when and if she can, and we'll keep our eye out for her as well. Thank you, Secretary Galley. Back to you.
Okay, so I just want to highlight to all the commissioners, the only one who said it's nice to be here is our newest commissioner, Michelle Bass. The rest of you are, you know, well, come on, we're gonna have a very great and incredible meeting. We're gonna do two things today. One is we're going to come back to the topic of community engagement, really reflect on the webinar that happened earlier in the week. Thank you to everybody who helped make that happen and who attended. But we're going to spend a few minutes at the top reflecting on that meeting and really thinking about what it means for the work, not just in the next few months, but moving on as we think about kind of the development of a playbook around unified financing. Where do we build in that role of community voice and making sure we capture Californians at the breadth and depth that we know it needs to be captured? And then secondly, sort of the big topic is going to be around our state-federal relationship, the concepts on what it's going to take for the state to work with the federal government to secure dollars and authority and the ability to implement a unified financing, single payer approach, if you will, to healthcare. Before I dive in any further, though, one of the things I really enjoy about the commission is all of you have day jobs, if you will, that really bring you into the conversations around healthcare and around issues of equity and how we're building a better California for all, as is our governor's vision, and I think the vision that brings most of us here together. And in those sort of moments of conversation in our work, we engage with one another in other ways. And I just wanted to turn to Bob Ross, who I had a chance to talk to a little bit over the last week and a half, and he wanted to share a few comments with the commission, and then I'll get into some of my tee-up comments to the next parts of our agenda. Bob?
Thank you, Chairperson Galley. I appreciate this moment. I just wanted to take an opportunity to speak to the commission. I was contacted by a fellow commission member who was offended by the use of terminology in an article I was quoted in, and I wanted to offer an apology and a little bit of context as well as to the use of that term. Some of you may or may not be familiar with the piece. It was a piece that ran in an article called, in a publication called Healthline. The reporter, the article ultimately landed on the theme of the possible effects of the recall election on the achievement of single payer in the state. When I was contacted by the reporter, it was not clear to me that was the intent of the article. The reporter called me, journalist I've spoken to in years past, who just wanted to know my thoughts about how the commission was progressing. And in the interview, and I was quoted accurately in the interview, but some of you are aware, you've done this in the past. Perhaps you conduct a 30-minute interview with a reporter, they pull out a sentence or two, and sometimes the context of the quote is not precisely the context in which it was meant. But I used the term zealot to describe a portion, or zealots to describe a portion of colleagues on the commission, and the context of my use of the term, and the term use of the term was regrettable and injudicious on my part in retrospect. I think the use of the term enthusiast or advocate might have been a better term. But here's the content. The context was the reporter asked me how I thought the commission was progressing. I said I think the commission was beginning to make progress, that we still have a lot of work to do on two very key things that we have to answer in preparation for any report to the governor. One is the what of what describing of a transformed system. What's it going to be and what's it going to look like in terms of a unified financing system? And secondly, the how of how to get there. That was already clear to me that we probably have to work through some tension around the speed to get there. Could it be a single bold stroke or leap, or might it have to be more incremental or phased? And so my use of the term zealot was in respect to that particular issue of speed and pacing and the roadmap of how to get there. So again, I apologize if anyone was offended by that term. It was not at all my intent to belittle or disparage any member of the commission. I have a tremendous amount of respect for the commission as a body, our work, and for each and every one of you as commissioners. And so if anyone, and I know at least one fellow member made their feelings known to me, and so I thought Mark would be best if I just got on the record with an apology about the use of that term. That said, and lastly, it's also my point of view that in the history of social change and social justice, spine is needed, courage is needed, enthusiasm is needed, I would even say zeal is needed. And so what we've got in front of us is not an easy lift. It's going to be a very heavy lift. I would imagine that whatever we send to the governor is going to bring on the forces that are wedded to the way the system is right now, and it's going to take great courage and spine for us as a commission as well as the governor to get there. But the history of social justice requires courage and spine, and I would say zeal. And so I have zeal for the mission of this commission. I have zeal for Health for All. I count myself among them. But again, I think the use of the term was poorly chosen on my part. And I just want to make sure that anyone who might have been offended by the use of that term receives an apology from me. Thank you, Mark.
Can I have a chance to respond? Because I think I was being referred to as a zealot. Mark, Secretary Galley, can I respond?
Please go ahead, Rupa.
So Bob, thank you for your comments. I want to be clear that, you know, in your response to me, you did identify yourself as someone who feels quite a lot of zeal about health equity. And for me, when we're talking about health equity, what we know from all the stuff that we've reviewed so far in the commission, if we're talking health equity, we're talking single payer. And so I wanted to know if you're a health equity zealot, which is how you characterize yourself. Are you a single payer zealot like myself? I took offense because the distinction was made between zealotry and bold incrementalism. And I'm home today. I wasn't supposed to be home, but I was exposed to COVID again in the hospital ward because that's what I do. I work in a hospital ward on the front line of this pandemic. And what I see when we have an emergency in the hospital, we have a code blue. And when you have a code blue, you run to the code blue. You don't walk, you don't dilly-dally, you don't do things incrementally, you run. Speed is everything when people are suffering the way that they are right now with our current healthcare system. And who's suffering right now are predominantly Black, brown, and poor people in this state. And so if we're talking health equity, we should not be talking incrementalism. We should be talking bold strokes. We should be talking, if you need to use the word zealotry, we should be talking about those bold strokes. And so from, I offer to this commission my experience on the front line. I know it was funny that Bob, in your email to me, you mentioned Dolores Huerta, that you've made a list of people who have that zeal to make social change. And Dolores just received a copy of my book. She's reading it right now. So I think that we need to take note of history. We need to take note of when things need to be done with swiftness and to be done well. That doesn't mean we don't do it well. So I just lay that, to the commission, that thank you, Bob, for apologizing. I hope we can continue to be cordial, and I hope we can be mindful of how we think about the work ahead. To me, it's an emergency, and it's an emergency because I'm losing patients. And I'm losing patients in so many ways that they don't have to be lost. And so I hope that perspective can be useful in this work.
And
I appreciate your remarks.
Yeah, I appreciate both of you and the dialogue that we have as co-commissioners and doing this work and thinking about the future for patients now, Rupa, as you mentioned, and I think the health systems as we think about them coming together in the future. And I do appreciate every commissioner's experiences in the work and how we carry, I'll say it again, our day jobs, whatever that looks like, to further these missions as we talk about them here in a more consolidated way. But I did think it was important for us to take a moment and acknowledge our conversations, not just the work in the commission, but how it plays out and the important conversations that happen outside of our monthly 3 to 6 hours that we spend together. So I wanted to come back as I promised, and we'll do this rather quickly, not because it should be done quickly, but because we have so much more to do on the community engagement piece. And I think some of the things, Rupa and Bob, that you bring up in your experiences and your comments here are reflected in what we heard. So Karen, can we put up the slides again, please? I'm gonna go through a few. So remember, we struggled with this. We knew always that we wanted to do community engagement as part of the commission. It started to look different after the pandemic came, and we weren't sure how we were gonna do it exactly. And that's when we leaned on happened to be three of the foundations that are represented, their leaders on the commission, to engage on a process where we would be allowed to hear, privileged to hear the voices of Californians who often don't show up at 12 noon or 1 o'clock on a Thursday to sit in our commission meetings, who are doing other things with their time and need to be, and we want to hear their voices too. Appreciate all those who can make it to our meetings, but we know that there are many voices in California, and often the ones that are overlooked and underrepresented are not often here. And so we did that through engagement of community-based organizations and understanding and asking very direct questions about experiences with healthcare systems, what people aspired for their healthcare system, and learned a lot about what people felt like were critical to the designs. I think we enjoyed engagement with over 2,000 people across California in a number of different ways. Some of this history lessons and looking at what had already existed, and others really fresh and new engagements of groups and people on surveys and conversations. And I certainly heard a lot and felt both reinvigorated and supported by what we saw. Next slide, please, Karen. So here are just some findings, and then I'm going to pull a few others into the conversation. 65% of those surveyed indicated support for a single statewide government-run healthcare program, with much higher support from communities of color. Affordability was a top priority, and I'll remind you, they looked at some of the more modern issues, things like, not that homelessness is a new issue for California, but certainly not always on people's radar like it is now, or certainly the pandemic. But one of the most consistent long-term durable issues for Californians is the affordability of healthcare and concern on cost. That there was widespread agreement that having health coverage didn't necessarily guarantee good access to health services. I think all of us are familiar with that concern and complaint. That there was a focus on, hey, we got to do better at integrating services, that certain things that we sometimes talk about, but not always, are really important: dental and vision. Long-term care, we've struggled with that and asked ourselves that question on this commission. People want it integrated. Behavioral health is, I think, the issue of the day for so many, and dominates people's healthcare agenda. And then those social support services and many issues in the social determinants of health space. One thing, and when I turn to Sandra Hernandez in just a moment, I know she'll emphasize this finding she did in our conversation on Monday, that people are very cognizant of how they're being treated by our delivery system. And if there's a call to action, and this certainly rings true in both Rupa and Bob's comments, I think that this idea of dignity and respect coming out of our systems is really key and important. And that 88% of folks, so let's say a vast majority of people, want to be involved in designing this new system. And that leads me to the next slide and a couple of questions before I ask Sandra and then call on a few others. What should we remember from this community engagement work? And then I think this came up, Michelle, I think Sarah, Carmen, you all, I think, asked a version of this question on Monday. How do we continue to engage the voices? How do we meet the request, demand to have communities, authentic community voice involved in building the system of the future? And so that isn't to say today we're going to announce a lot more engagement in the next few months. We would like to, but it's beyond the scope right now of the commission. But I think we do need to think about how this informs our recommendations to our leading legislative partners in guiding where this work can go. So with that, I want to thank Sandra, you, Antonia, Bob, your teams, the consultants who put together the various string of work, all of those who joined the conversation on Monday, and then invite some conversation, and then I'll wrap us up before we get to the next part of the discussion. Sandra?
Sure. Thank you, Mark. And really, I want to thank all the commissioners that joined us on Tuesday for what was really a very rich webinar and perhaps more importantly, a rich discussion that followed. You know, everybody on this commission recognizes that any redesign, restructure, single financing, in order to get it right, we not only need to have the voices of the people who use it, and particularly the voices of people for whom the system really does not serve well today. We just have to figure out how those voices are not just at the table, but are central to the table and central to the conversation and the discussion. You know, it was mentioned by one of our fellow commissioners at the webinar that, you know, Professor Chow, I think, raised this, that, you know, at the end of the day, there are a lot of trade-offs that need to be made. And what I would say to that is that's absolutely right. He, of course, was talking about it from an economics point of view. I think the trade-off should not be between living and dying, or having a good quality of life or not having a good quality of life. Those are not the trade-offs we're talking about, but it's more about trade-offs on what gets included, how much choice, you know, sort of the third and fourth level set of trade-offs, but not that we shouldn't be have any question in our mind that we're trying to design a system that treats everybody with dignity and respect, and that that their voices are central and not just an add-on at a table. So that was sort of my big takeaway, Mark, from the conversation. As to the actual work that was done, I would just say, it is the responsibility of philanthropists to do things fast and do them responsibly and to do them in a way that's got utility. And so I know Antonia and Bob and I were happy to pitch into this, and our teams in the middle of a pandemic with a very short turnaround, I thought just did an exemplary job of both reviewing all the literature that's out there. I mean, we've got low-income surveys that we've worked on. All of our advocacy groups and many of the panelists have issued their own reports. And so that summation of all that work, important and valuable. Likewise, just talking directly with nonprofits who serve these populations for us, and their observation about just how ridiculously complex our system is today, and the real desire to make it a much simpler system, in addition to many other components. You know, if I were going to sort of I think under the circumstances, given how important this voice is, given the fact that we're in pandemic and we're not live, really I'd echo Mark's comments that we listened to a lot of people, reached a lot of people, and the report is rich, and I hope people have a chance to review it. You know, as we think about what does it look like going forward to make sure that this voice informs reform, and that the values and things that matter most are central. I do think it does take time. It takes explicit budget. And I think most importantly of all, it requires the willingness to take on existing power structures. What we're talking about here is changing the power dynamics in the way that we deliver wellness and healthcare going forward. And I'm sure we're all sanguine. Antonia made this point, but I think we're all sanguine that is something that will not be easy. It's always easier to stay in inertia than it is to to move forward. And I think the reports and what we heard emphasize that. I wanted to name something that really Mark's overall comments didn't, but that really come through in the report. And that is that our workforce today does not remotely look like the beauty of the diversity of the state, not in language, not in culture, not in economic backgrounds, not in a number of ways in which this state is diverse. And we're not going to turn that on a dime in terms of getting a workforce that is culturally capable of delivering our best overnight. That said, we have a lot of talented people in our communities, our promotores, our community health workers, who are absolutely invaluable. And the administration has moved forward to say we should pay for those services. And that's an enormous resource that we all need to lean into and lift up, because they can help us get to a delivery system that comes closer to reflecting the demographics of the state. Let me just pivot to maybe, so how do we move forward? What are there models that we can build on? And Mark asked if I would address that. And I wanted to name one because it strikes me as it's been evaluated, it's got high quality outcomes, and even though it's not, I mean, there are many demonstrations of things that work in California that we haven't scaled. But I want to name the Alaskan Native Medical Center, which was a Native American and Indian Health Service program that was really taken over by the community and created what's called the NUCA system of care. And it's notable in large part because its goal was to transform the way healthcare was delivered, to improve outcomes and to reduce costs, and to do so in a way that actually addressed the needs of the Native Alaskan communities. And it was a whole system transformation, whereby the delivery system was a consult to the community itself and to the patients and families that were served by that clinic. It really does turn the delivery system in on itself. And so, you know, I, as a primary care physician, you know, Maria was talking about this, you know, any first interface you have with a patient is a subjective one. What matters to you? What are you concerned about? And what we do is we put that in a subjective line, and then we, you know, work up their creatinine and try to figure out, you know, all the medical aspects of it. And what this system does is it starts with that, and you don't do anything in that visit. And it's largely a primary care visit. It's integrated, it's value-based. Behavioral health, physical health are incorporated. There's an innovation arm, so we should not ever stop innovating. And so I think it's an example of what's possible. And I think if we don't have a vision of what's possible, we'll live in the world of principles for a long time, most of which we all share. But can you get to a delivery system where consumers are actually driving it and not just an add-on at the end of the table? And I think this is a really good example of it. We brought them here, I don't know, in 2018, before the pandemic, as part of an effort. We were looking at physical health and behavioral health integration. And they have speakers, Mark, and they have training capabilities. And so I just hold it up as an example of what's possible. And, you know, they've taken on things like domestic violence and high rates of alcoholism and fetal alcohol syndrome. I mean, it really is a population-based approach. So I think the principles that we have and envisioning what they look like exist. And so I think, you know, the takeaway from the webinar on Tuesday, you know, I think Commissioner Woods said, we're going to have to get the whole state behind this, and that's certainly true. All the different segments, commercial, employer-based, et cetera. Low-income folks are really good at making trade-offs because they do it every single day. And I think those decision-making capabilities are ones that we should really embrace. Yes, we have to reach a lot of other folks. But I don't think we should underestimate the fact that, when people are asked to really sit down and say, what are the trade-offs? It isn't just go any provider for any care to get any antibiotic they want. That's not what we're talking about. And I think what we've seen is we've got very strong advocates, a lot of consumers that help folks navigate a very complex, fragmented system. And it doesn't have to be that way. So I'll stop there, Mark. And again, I want to appreciate all the teams that did all the work. Commissioners who haven't read the report, it's absolutely, it's a Bible really on both what people want to see out of this effort and also about what values we should continue to hold our hat on.
Thanks, Sandra. And just to touch on two things you said, and then maybe take one or two more comments from commissioners. And as always, we never have enough time to dig in to the things we want to, as long as we would like. But I'll just say a couple of things. First, I think we all received some good public comment about the trade-offs conversation. And I think we should all just be alerted that, there's trade-offs of different kinds and different levels. And Sandra, I think you focused on, well, we can't trade away a system that delivers good healthcare for all in California. And then there's the conversation about trade-offs within the healthcare delivery system, and many who feel like some of the opportunities to streamline and bring things in a smarter, more efficient way are going to allow us not to have to make some of the trade-offs we think. So I just want to put front and center this trade-offs conversation because I think it's an important one that we think about as we craft our forward direction. And then just a moment on workforce, and thank you, Sandra, for raising it. I will tell you, as somebody on the receiving end of so many of the workforce challenges in California, I think this commission should really see the work we're talking about as the opportunity of a lifetime to really try to address some of the important workforce issues of decades old, and the fact that we don't have a healthcare workforce that looks like the Californians it's meant to serve, speak the languages of the Californians it's meant to serve, and really think about what the opportunities are given COVID, given the real pressure to create programs to invite a lot more Californians into this work that are eager and interested and bring a level of experience and commitment that I think we miss out on. So just as we think about the riveting change in front of us, not just for the commission, but in other walks of our lives, like, let's keep that front and center. I'm going to bug two people, and then Anthony, I always come to you, but I am curious. You were great on Monday, and I just want to come to you. And then Sarah, I'm going to bother you as well, just to get a few comments on the webinar, and especially that second question on what we're going to do to reflect in our report this need to engage consistently, patiently, and with the resources needed to really hit a home run on this issue. So Anthony, you first, please.
Yeah, no, I appreciate it. And I think, as I said on Monday, I thought that it was very important to get that data and both qualitative and quantitative, that there's a lot of great support, for the concept, but more importantly, need and urgency from people and their experience about improving our healthcare system and getting to these goals. And some of them we articulate well, like universality and especially affordability. Affordability is, for a lot of people, is how people experience the healthcare system and how they and the problems with it, and also some things that we need to do a better job of figuring out how to articulate, questions about having about dignity and respect and simplicity and, you know, we recognize that there are some parts of the healthcare system that are by their nature complex, and but there are lots of parts of it that are needlessly complex, and that there are and even with regard to the complexity that may be necessary, how do we make sure that that is not something that's experienced by the consumer, especially at the time when they're the most vulnerable, right? That there's lots of technologies we live with in our life that are complex internally but simple to use, and we need to figure that out. I think in terms of engaging people's people through this process, I think that our end result should have something that I think Kieran and others talked about, having making sure that this is embedded in our governance and our philosophy, that people's views and thoughts are incorporated throughout as an end goal, but then also make sure that that process is there. And so I think that there may be ways as we, I don't know, we should make sure that whatever product that we produce in February is not a report that lives on a shelf, but has some iterative and ongoing features. Some of that will, maybe done through our more standard legislative and policy processes, but I think that I think we can envision how do we engage folks? And again, I do think that the final thing I would want to say before deferring to my colleague Sarah is just I do think that we always need to be mindful of both like broad public opinion and the specific experience of those that are the most impacted. I don't say it to dismiss the broad public opinion. 80% of us don't really deal with the healthcare system on a regular basis. We know that by age or accident, we will be in that 10, 20% in any given year, but in our daily lives. But I do think that the health system does weigh on those people as well. The insecurity, the fear of that they're one emergency away from financial ruin. People make life choices based on that, and so I do think that is something that we need to be mindful of about the people whose main experience with the healthcare system is paying premiums, copays, etc., and their annual checkup, as well as, but we need to absolutely focus on the folks that whether are dealing with a variety of barriers, racial, ethnic, income, immigration status, but also just being a patient, that they're the ones that know the healthcare system the most, and they're the ones that we need to center. And I know that's just underlining what Commissioner Hernandez already said, but I think that's what we need to do in this process, and and that needs to continue past the end of our commission's work in February.
Thanks, Anthony. So Sarah, I'm going to have you go. Jim, I see your hand up. We'll go to you next, and then I'm going to move us into the next part of the conversation and know that we can come back to some of this again down the road, and I think we should. But Sarah, go ahead, please.
Yeah, once again, it was an incredible webinar and an incredible body of work, and very much appreciate it. I think my comments during the webinar were mainly focused on how striking the level of cultural disrespect and discrimination that patients faced in the healthcare system, and how that is a huge barrier to a universal system. And that so much focus, I think, needs to be put on how we measure that, how we correct it, how we hold providers accountable. I did not make a comment on how we do that because I would look to others and their expertise. But going back to what Commissioner Hernandez said about the many different providers in communities, whether they're promotoras, whether they're people who are doing home visits, whether they're unions or community-based organizations, or any group that is serving as a bridge between communities and workplaces and health facilities and clinical practices. I think is important to engage in a real way as providers and practitioners. And then just also wanted to point to another agency. I was actually speaking with the people who work for the Labor Commissioner's office the other day, and they went on a statewide car caravan visiting farm workers up and down the state to talk to them and their employers about their rights and new laws under COVID and supplemental sick leave. And to just have the Labor Commissioner, like the head of an entity, driving from Arvin to Fresno to Cutler, Rossi to just all over the state to meet with farm workers and hear their experience was really striking. And I think having that ability to go to where people are at the top levels and throughout whatever the governance structure is in this entity is going to be really important as well.
Thanks, Sarah and Anthony. Jim, jump in, please.
Yeah, thank you very much. And I just want a couple very brief comments. First of all, for us to be successful in our mission to help create this system here, one of the critical components I want to point out is going to be workforce. I worked sat on the Workforce Commission that was convened by Commissioner Hernandez with the California Healthcare Foundation. And we laid out a pathway to get there. And so far, we haven't made the progress that we need to make. We need a workforce to provide care to people that reflects the nature of the population in the state, and we aren't there. And we need, if you want to talk about a bold step that is important and foundational, it is a huge investment in our workforce. And I think that's really, really important. And the second piece of that, the second thing I just want to ask, I want to delve deeper into the survey that was done by FM3. And because I want to understand the people, I want to understand the demographics and maybe some more background on the people that didn't think these things were important. Because to me, had you asked me all those questions, every single one of them would have been important. But there are parts of the people that were surveyed there that didn't see the importance. And I'd like to understand more about who they are and what their resistance to some of the concepts that we're discussing are, so we can better understand that and hopefully overcome that. So thank you.
Right, thank you all. And yes, the workforce piece, there's tremendous opportunity and a lot of work that's been done to suggest paths forward, and taking those steps are going to be key. And I hope to be part of the team that leads some of that work moving forward. And then to your second point, you had shared with me interest in getting some of the background information to the survey, and we're trying to make that available. We'll make it available to all, so you can take a look at it. Okay, let's move on. First off, no one has sent me nasty texts or anything noticing that there is no break to this meeting. We're just going to keep on going through. A lot to talk about. Let's start into the longest part of our day in our discussion, what I teed up, the state and federal relationship and financing mechanisms. I want to just start by thanking Carmen and Andy for agreeing, never with enough time to do as much as I think they want, but they came up and said yes to agreeing to present. So just really grateful, Carmen, your experience working both locally and analyzing the federal opportunities and landscape. I couldn't miss the opportunity to have you share some of your thoughts, experiences, and real understanding of what the opportunities are on this space. And then Andy, your long history of helping write Medicaid law. We've talked about in our relationship, everything to how we use the tools of financing in Medicaid to support people coming out of juvenile detention facilities, and then FQHC financing in the PPS system. So your history and knowledge in this space, both of you, really grateful to have you presenting here. Before we dive into this, I wanted to share a couple slides, and then I'll turn it to you, Carmen, first. Could we go to the next slide? So just to give you a sense, and look, I'm learning from you all every single day. So I have to think about things in as simple a way as I can. And when I think about what we're talking about with unified financing, to me, it's, well, what's at stake with the federal money? And so it was important to share, you know, in 2019, $441 billion of total California healthcare expenditure. And roughly 35% that tracks nationally comes from these federal sources. The remaining 65% comes in these out-of-pocket expenses at 11, roughly 7 to 10 comes from state funding, other spending. I think you can see that it's a mix of different things, and then private insurance premiums makes up a third. So when we talk about the importance of really working with our federal partner to make a unified system as flexible and everything we want it to be, this 35% or roughly $156 billion is key to understand the rules around and understand how the system that we would propose can really become what it becomes because of these dollars. Next slide. And this is just a look to remind us that even when we talk about it being roughly 35% today, that hasn't historically always been the case. It's gone ups and downs, but generally up. And so what we think about in terms of the remaining or the relationship with federal partners today needs to continue to be dynamic. We need to understand the approaches that we would take and allow us to have room for change, agreements for change, et cetera. So what we might propose today does need to be fluid for us to achieve what we want to achieve. Next slide. So some key questions that I'll just tee up and then quickly turn to Carmen. You know, unified financing, I struggled. I said was going to do only feasible, but it's a decision. You could say, well, we don't need to figure out the federal side of this, but absolutely, I think everybody here would say we must for this to be feasible. And in order to do that, I asked the questions, what are those strategies to secure the funding? Today, we're going to hear about waivers. We're going to hear about legislation. We're going to hear about other things, concern around ERISA, some other issues that we would have to contend with. What are the hurdles to securing this funding, federal support, and what are the opportunities, not just hurdles? How does California clear those hurdles, take advantage of opportunities, and how do we ensure the sustainability? As I pointed out, it's been fairly dynamic in the recent history, and striking a concept and a focus today may need to change in the future for us to deliver on the promise that I think we all want to make commitment to Californians around affordability. So next slide, please. So with that in mind, we'll have about 10 to 15 minutes. 15 minutes, Carmen, please. You know, I know Andy, I was joking with Andy and Carmen that they'll keep track of their own time. Andy, let me know he's at 10. Carmen, take the time you need to make the presentation, but we'll come back roughly 30 minutes in and then really go back to our commissioners to ask these two terrific presenters about their presentation. Commissioner Scheffler, Richard, you were joking that you can't wait to learn. I'm in the same boat. I think we're all going to learn a lot here about some of these opportunities. And then I'll do what I've done before, which is pull you as commissioners into a conversation. And then we'll take it into the public comment period. But with that, Carmen, take it away.
Thanks, Mark. If we could go to the next slide. So there's a lot of ground to cover, so I'm going to jump straight in. My goal here today with the presentation is to really help dispel some of the anxieties and myths surrounding federal waivers and federal authorities. But before we go into some detail, I want to give some key takeaways now. The first takeaway is that yes, we can integrate federal programs with a state unified financing system, What we want to do is understand the rules so that we can build a program within the statutory parameters set by Congress. And the second takeaway is no, we do not need to change federal statute to secure federal financial participation in a unified financing program. And the federal government and California have implemented new or better ways to get Medicare and Medicaid beneficiaries their care before. It's not new. The only new part is that we want everyone, not just some people, everyone in California into the same comprehensive program. Now, what are federal waivers? The simple answer is that a federal waiver is when specific healthcare laws are being waived by the Secretary of Health and Human Services. Congress says how and when laws can be waived. HHS waives those laws within the rule book set by Congress. States apply to waivers to CMS. Some waiver authorities are fairly detailed on guardrails, while others are fairly open-ended, giving discretionary latitude to the HHS Secretary on approvals. Importantly, although waiver statutes may not explicitly list single payer as a program HHS can approve, that does not mean that the Secretary is prohibited from approving such a program. Now, why would California want a waiver? Well, one, we want everyone in one system. And two, we want to take the benefit, we want to benefit from federal funding of health programs in California in a way that really remains seamless for the people enrolled in our system, regardless of whether they're eligible for federal programs or not. And three, we want to make sure that the state program can use federal funds that would have been paid to the federal program beneficiaries if we didn't have a waiver. Next slide, please. To back up a bit, I want us to think about how we approach this question to federal financing. I've heard a lot of people rush to ask the question, will the feds approve a state single payer program, a unified financing system? Chomping at the bit to know whether or not a state program will or will not be approved. But this question puts the cart before the horse. We cannot answer this question until we have designed a program. And I want us to reframe our thinking and ask, what are the rules, what's out there, what's available, and how can we construct a system to fit within those rules? And in a similar vein, I don't want us to get stuck on the idea that California absolutely needs federal funds to be passed through, used through pass-through funds or block grants or other massive transfer funds or deposits to the state with little or to no strings attached, because we really do not need federal financing to look like a block grant program. And I want us to ask instead, what are the ways that exist right now where we can get federal dollars to reimburse benefits under the state program? What's the level of administrative oversight that CMS might want over federal dollars? Instead of block grants or pass-through funds, we should be looking for ways the state can manage Medicare and Medicaid reimbursements. Perhaps we need to work with CMS to have some monthly accounting or annual budgeting, or we need a system where the state program functions as a broker between Medicare and Medicaid providers and the federal government. And I think it's important that we should recognize that that even though no state has done this before, that does not make it impossible. Sure, we have to navigate parameters of different waivers, and sure, HHS hasn't approved a unified financing program before, but that's because no state has yet to present such a program to HHS. We need our leadership in California to take the lead and be the first state to put a single payer proposal, a unified financing proposal together and make the ask to CMS. The state of California, our legislature and governor, the onus is really on us and on them to present a formal plan and approved under state law to CMS. We'll never know until we try and ask. To get to more of the wonky aspects, California designs a program first, then we apply to CMS, CMS reviews the waivers, and then at that point, we can engage in formal negotiations with CMS. Next slide, please. So there's a lot of information here on this chart, and I'll just tell you some broad strokes. There's several major waiver authorities that Congress has created on federal healthcare programs, which you can see. These waivers, there's some demonstration waivers or innovation waivers, which would allow a state to change or expand federal program requirements related to federal program benefits, administration, service delivery, creating new types of provider reimbursement or payment methodologies. In Medicaid, the 1115 demonstration waiver to test new healthcare delivery models. California has had one of these for decades. Medicare, there's also the innovation waiver for states to test and evaluate new models for Medicare, Medicaid, and dual eligible beneficiaries in the state. And it's important to note that the Medicare innovation waivers, although it lists 27 models that could be tested, the HHS Secretary's discretion to approve new Medicare delivery models is not limited to the models listed in statute. There's some major requirements that come up with many of these waivers that are in state waivers that the state program has to be consistent with federal program objectives, and that federal spending to the government cannot increase under a waiver. Next slide, please. So the second chart, there's a lot more, there's a lot of waivers. So the ones I want to point out is Section 1332 of the Affordable Care Act, which gives HHS authority to waive ACA requirements. And importantly, an ACA waiver has a process, a coordinated and consolidated waiver process, which allows the state to apply for all necessary federal healthcare waivers needed for a program in a single application. And I'll mention a little bit more about these in a bit. So HHS also has statutory authority to contract out administrative functions like payment determinations and reimbursement. So HHS potentially could enter into a contract with a state to administer Medicare. And there's some other waivers that aren't mentioned very often in this discussion, but I think are important here, where the state could manage Medicare and Medicaid beneficiary enrollment and benefits. So both the Medicare Shared Savings Program Authority and the Medicaid authorities that are generally known as freedom of choice waivers, these together could be used to get a unified financing program approved as a statewide shared savings program. Next slide, please. So how do these waivers work together? This is where Section 1332 of the ACA comes in, because the state would need multiple waivers through multiple authorities to incorporate a number of federal programs. We'd want the state to use Section 1332's consolidated and coordinated waiver application process. And in this waiver application process, a state must show it has met the requirements of all the different waiver authorities it's applying for, in addition to the procedural and substantive requirements of 1332. And with 1332, the important part of the consolidated waiver is that it has a state law enactment requirement. So this means that the state needs to go into the consolidated waiver application process with necessary state legislation already passed. So in other words, we need a bill passed in hand before we can apply for a consolidated waiver. Of course, we can design a unified financing bill. I've done this in AB 1400 that gives the state enough flexibility to apply for different waivers or to make adjustments if the feds ask for it. And this state law enactment requirement gets into the question of formal negotiations versus informal discussion. To initiate formal negotiations with HHS, California, meaning the legislature and the governor, need to enact a program in state law. We can't jump straight to talking to HHS. Any discussions with Secretary Becerra before an application is submitted, it wouldn't be binding. And we wouldn't want to put the state in a position where we have informal discussions that are drawn out to the point where there's a transition in power and all those informal discussions become moot. And also the HHS secretary doesn't have authority to pre-approve waivers. So again, it's important that we get legislation moving and passed so that we can submit waiver applications to the feds and start formal negotiations. And it's important to note from our previous discussion that the Biden administration has signaled that it wants more public transparency and participation before HHS reviews waivers. And the legislative process to hold public discussions, legislative debates on program designs, that can help meet that call from the Biden administration and the calls that we heard earlier this week from community stakeholders to be at the table in the discussions on system redesign. Next slide. Now, I want to quickly talk about the budget neutrality requirements. It's really detailed, but I'll just go through it really quickly. The budget neutrality calculation is important because it sets a dollar amount for the federal share of funding that a state could get under a waiver. The key points here is that the budget neutrality formula is not set in statute or regulation. CMS has some guidance for a couple of different formulas, a per capita formula and an aggregate cap formula. Again, this is all CMS guidance, and so these formulas aren't necessarily set in stone, and we would not need federal statutory changes to change these formulas. Next slide. Now, to briefly talk about federal waivers in California, the California Department of Healthcare Services is in charge of the waiver application and administration process. We have comprehensive 1115 Medicaid waivers since 2005 and some before then also. And we have a number of other specific waivers on mental health, home and community-based services, among others. And in this slide, I want to show you all that in California under Medi-Cal 2020, which uses an 1115 Medicaid waiver, California has already applied the budget neutrality calculations pretty creatively to maximize the federal share. The point here is that a combination of levers can be pulled to maximize the federal share, and we're actually doing that right now. And just really briefly, I want to mention both Vermont and Maryland's Medicare innovation waivers here. An important principle has been tested with these two models. These two models show that yes, CMS is willing to approve waivers that state programs that include a mix of all patient populations within a state, including people whose care is covered by federal programs and whose care is covered by non-federal plans. CMS is willing to approve those types of waivers. Next slide, please. To quickly touch on some other considerations, one, I just want to reiterate a point from earlier. Under unified financing, we're really asking the feds to provide Medicare and Medicaid beneficiaries their benefits through a state program. It just would happen under a different name in a new way. And second, on the sustainable financing question, part of this discussion really requires us to look at the diversity of non-federal revenue sources that are available. And we as a commission have the opportunity to really move this ball forward on the question of non-federal financing. And I said this before, and I think we should create a tool with multiple financing options and multiple tax rates for the legislature and the governor, and put this in our final report so that they can start tinkering with some of these financing plans and start a serious debate among electeds on non-federal revenue sources, like a choose your own adventure of financing. Giving these types of options is really important because the legislature has been asking for it on single payer for literally decades. And the commission has the opportunity, the mission, and the resources of our consulting team to give us this kind of analysis and to provide it for the legislature. And then on sustainable financing, some tools in our toolbox that could be used, which hopefully we can talk about later, are global budgeting for institutions or hospital global budgeting, bulk price negotiations, whether it's drug pricing or rate negotiations with providers. And again, looking for ways to maximize the federal share through budgeting formulas. And then a couple of other things, you know, we will probably have to do some accounting between what can be paid for through the federal share and what must be paid through the state share, like how we have to do that today under Medi-Cal with our coverage for undocumented adults. And then another thing to keep in the back of our minds is that, you know, there are federal healthcare proposals on the table that could greatly increase the federal share, long-term care funding, Medicare expansion, and change the game. And then, you know, I don't have time to get into this, but Becerra versus Gresham has the potential to change the discretionary authority of 1115 waiver approvals. And the Biden administration in its legal briefing is actually asking for a broad interpretation of waiver approval authority, just as long as there's no substantial coverage loss in Medicaid. And finally, on the question of budget neutrality, I want to bring to everyone's attention the consulting team's modeling on aggregate savings and unified financing. When looking at those figures that they gave us a couple months ago, even using the conservative assumptions that they use on savings, California would save money relative to the status quo in year one of the program, and that's with no cost sharing. And then if we add in long-term care for everyone, we reach savings by year 3. And next slide. And then really quickly to wrap up, what are the takeaways again? Can California integrate programs into a state financing program, unified financing program? Yes. And how do we do that? First, we pass legislation enacting the program that we want and ensuring that the program meets or exceeds the benefits under federal programs. 2, we apply for a combination of waivers to incorporate Medicare and Medicaid beneficiaries into the program. 3, we ensure the program meets the needs and guardrails set by the feds. We ask the HHS secretary to broadly exercise his discretion. And lastly, we need to make sure that we get CMS the appropriate budgeting receipts they need. And then similarly, do we need to change federal statute? No, we don't. Rather, we need to develop a program that meets the parameters of the waivers that do exist, and then we administratively integrate the federal programs into the state unified financing system to make it seamless for everybody. That was really quick. I don't know how long I went, but I'm happy to answer questions later.
Carmen, you did amazing. That was, you went through a lot quickly, and there will be a chance to ask a lot of questions soon. I wanted now to turn to Andy to offer a presentation. One thing I'll just highlight before, Andy, you go, one of the things that I've really been pushing us to think about is the concept, you know, if we're doing, not if, but that we are doing a unified financing system, that we're interested in figuring out the strategies and approaches to best secure the federal dollars. And today is a conversation about not just is it possible, should we do it, but what are the concrete steps? So Carmen, appreciate the quick lesson in the concrete steps and some of the thoughts on what we should do. And similarly, Andy, I know you'll run through some of the same issues from a slightly different lens. So take it away, please.
Afternoon, everyone. So I'm going to try to be even more expeditious than Carmen. The affiliation here with Georgetown and the Center for Children and Families, I'm not speaking on their behalf. I hope that's clear to everyone. These are just my own professional views on this. So could we have the next slide, please? All right, so here's the question that I am going to answer. Can the Secretary of HHS transfer federal Medicare and Medicaid funds to a unified financing system in California? And the answer to that, short answer, is no. Not an authority. The rest of the slide presentation is going to walk through how I get to that. I should say, I do have a bias here. I worked in the Congress for many years, and there's a long-standing tug between the executive branch and the legislative branch over who's got the authority to make major policy decisions. And even though I worked for some years at CMS, I'm still at base a legislative branch guy. So you can take that into account as you listen to this. Next slide, please. So the Secretary of HHS has no authority by waiver or elsewhere in the statute to transfer federal Medicare funds to a state for a unified financing system. Secretary of HHS has no authority by waiver or through the Medicaid statute to transfer federal Medicaid funds to a state for a unified financing system. If California wants to use federal Medicare and Medicaid funds as part of a unified financing system, single payer, it is going to need to persuade the Congress and the president to change federal law. Next slide, please. Okay, let's start with Medicare. So as you heard from Mark's presentation, Medicare is a big deal in California health spending. That's the 2019 spend, $89 billion. And that if you looked at that as a percentage of federal Medicare spending, it's also a big deal. It's about 14%, or about 1/7 of all Medicare spending by the federal government in that year. 6.3 million Californians enrolled. Each of them has an individual entitlement to a defined set of benefits under Medicare. Medicare makes payments on behalf of those beneficiaries for the services it covers to providers and to Medicare Advantage plans and to Part D plans. It does not make payments to states. The Secretary of the HHS has some authority to waive compliance with some Medicare rules. We're going to go through that in a second. The authority does not allow her to transfer Medicare funds to a state or to its unified financing system. Next slide, please. Okay, one of the authorities that Carmen mentioned is Section 402 of the 1967 Social Security Amendments. You remember Medicare was enacted in 65. Right after that, Congress said, well, let's think about giving the Secretary the authority to start doing some demonstrations to see if we can improve the Medicare program. And the way these authorities get set up is there's a general purpose for the authority, then there's a specification as to what particular rules the Secretary can change. And then there may or may not be some additional money for the Secretary to spend to do the demonstrations. We'll come back to this theme again and again. So 50-year-old plus authority. This allows the Secretary to conduct demonstrations or experiments to test, quote, methods, changes in methods of payment or reimbursement for healthcare service under Medicare and Medicaid. Okay, so what exactly does he have the authority, or she have the authority? In the case of any experiment or demonstration project to change methods of payment or reimbursement under A, the Secretary may waive compliance with the requirements of Title 18 and Title 19 of the Social Security Act. Okay, if we stopped right there, it'd be really broad, but we didn't. Insofar as such requirements relate to reimbursement or payment on the basis of reasonable cost. Those of you who are as old as I am will remember reasonable cost reimbursement. It's not very common right now. Or in the case of physicians, on the basis of reasonable charge. Another rapidly disappearing artifact of the past, or to reimbursement or payment only for such services or items as may be specified in the experiment. Okay, 402 is all about changes in payments in methods of or amounts of reimbursement, nothing else. Next slide. 1115 Cap A of the Social Security Act. This is a much more recent vintage, enacted during the ACA, and has been, in operation for around 10 years. This authorizes the Secretary to, quote, test innovative payment and service delivery models. Payment and service delivery models to reduce program expenditures under Medicare and Medicaid while preserving or enhancing the quality of care furnished to individuals under such programs. And then it goes on to list 27 different types of models. None of them, as it happens, is unified financing system. As Carmen pointed out, there are some all-payer models out there where a state can use, if it wants to set rates for hospitals, for example, like Maryland is doing, it can take Medicare and make it part of that hospital payment system. But in that circumstance, Maryland is telling Medicare what to pay, and Medicare is agreeing to pay that rate. But Medicare is still doing the payment. Medicare is not sending any money to the state of Maryland. Secretary may waive under this authority such requirements of the Medicare law, in this case, as may be necessary solely for purposes of testing models, nothing else. You can't mess with Medicare eligibility. You can't mess with the Medicare entitlement. You can't change Medicare financing. Next slide. Okay, Medicaid. Also a pretty big deal in California. Not as big as Medicare, but still pretty big. Also a big deal nationally. And that 62 billion was about 15% of the total Medicaid spend nationally. 12.6 million Californians in 2019. We're now up to 14 million. They each have an individual entitlement to a defined set of benefits. Now, Medicaid is a federal state matching program. The federal government does every quarter send money to the states. As you can see, for 2019, 62 billion the federal government sent to the state of California. That was a match. It was a match on an open-ended basis. The state spent its share of the total cost. The federal government share is 62 billion. And what the state was paying for in claiming federal reimbursement on was the covered services for those 12.6 million Californians to which they were entitled as part of their individual entitlement. So the secretary has the authority under an authority we're going to look at to waive compliance with certain rules. They don't allow the secretary to just transfer federal Medicaid funds to the state unified financing system. Next slide. Okay, so here's section 1115 of the Social Security Act. It authorizes the secretary to enable states to conduct experimental pilot or demonstration projects, here come the magic words, which are likely to assist in promoting the objectives of Medicaid. What you might ask are the objectives of Medicaid. As Carmen pointed out, that's a matter before the Supreme Court right now in Becerra v. Gresham. That case came out of a fight over whether the previous administration could allow states to impose work requirements on Medicaid beneficiaries as a condition of receiving coverage. And the lower courts have said, no, they can't. We'll see how that comes out. In the lower courts, the purpose of Medicaid is, of all things, to promote coverage, not to take it away through work requirements. We'll see where that goes. So for such projects, the secretary may waive compliance. Again, we have a purpose. Now we have, what can the secretary waive? Any of the requirements of section 1902 to the extent and for the period he finds necessary to enable such state or states to carry out such projects. So California right now is in the midst of discussions, as you all know, around CalAIM on this very issue. What can we waive in section 1902 to allow the state to go forward and transform its healthcare delivery system? That's all great. And that's exactly what section 1115 is designed to give the secretary authority to do. Here's the problem on the financing front. The open-ended matching arrangement, which is the entitlement to states for the federal government to match all its expenditures for eligible people for allowable services, that's in section 1903. It's not section 1902. In section 1905, is the match for California, for the expansion population, for the Indian Health Service related population. All those matching rates are there. Can the secretary waive them under section 1115 as it's now written? No, he can't. The secretary does not have the authority to do that. He only has the authority to waive section 1902 requirements, and only if they promote the objectives of Medicaid. Next slide. Okay, we had some other authorities floating out there. Most of the conversation on the Medicaid side has been around 1115, but just to close the loop, if we want to go back to that 50 whatever year old authority, the secretary may waive Medicaid requirements, insofar as such requirements relate to reimbursement or payment on the basis of reasonable cost or on the basis of reasonable charge in the case of physicians. Not relevant to the question of unified financing. Section 1115A of the Social Security Act. Secretary's waiver authority on the Medicare side is broader than on the Medicaid side. And there was a reason for that, because the people on the Medicaid side, when this issue were very leery of the misuse of waiver authorities because of the unsatisfactory history under 1115. But here we have 1115 Cap A. There were 4 things that the secretary can waive. The requirement that Medicaid be in effect statewide, the requirements relating to payment for hospital and hospice services, not FQHCs, hospital and hospice services. The requirement that if a state goes down the Medicaid managed care route, that it pay its MCOs actuarially sound rates. Secretary can waive that to promote one of these test one of these models. And finally, there's authority to change certain requirements in the PACE programs. That's it. Next slide. So I've listed here some other analyses. This is the reading I did to prepare for this. You can see there, these are different authors coming from different perspectives. They reach somewhat different conclusions. A lot of them are the same. I don't think there's anything in here that directly contradicts what I just presented. I don't want to speak for those authors. That's why I put them here for you to examine for yourself. And that concludes my presentation.
Terrific. Thanks, Andy, and thanks, Carmen, to both of you. And as we have open conversation with the commissioners, as we've done in the past, it's important to have Carmen and Andy available to answer questions specifically about their presentations. I know there's probably a lot. And then also being able to participate in the conversation as well, because I know I don't want to confine you both to the questions in the presentation, but the broader conversation. I see, Peter, you have your hand up already. I just wanted to take a minute before we jump to the general conversation. I'm going to ask Commissioner Wood, Jim, if you wouldn't mind, you sat on and helped run an Assembly Select Committee that thought about some of these same challenges and questions. And I just wonder, we heard from Carmen and Andy, and I'll just acknowledge it, fairly different sense of what is doable, right? And remember, I am not so much interested, although we do have to not ignore or dismiss the realities of what paths are available to us, but to really understand. I mean, you heard from Andy where you might not have just clear waiver authority. There are some legal legislative options that could be pursued, and Carmen with some ideas on where the waivers may actually be useful. And I think we'll get to some of the questions that get to the heart of that. But before I get to your questions, Jim, I'd love to invite you to offer either some reflections, but also your experience on that select committee from a few years back.
Well, thank you very much, and I very much appreciate both perspectives and the discussion before us. I would note that one of the resources that Andy spoke of was Juliet Kubanski, who was one of the speakers at in February of 2018. And so the conclusions that Andy has come to, based on not only her work but the work of the others, is consistent with what we heard in the committee. That it is, while yes, we certainly have the opportunity to pursue waivers, who can actually has the statutory authority to do what we're asking to do is a question. And the conclusion that we heard from our presenters was that it indeed would take federal statute to change that. Now, people can disagree with what we're hearing, what we heard, and we're also hearing the same message from Andy as well. And so the other issue around waivers, which is important to consider, is that waivers are typically time limited. And they have specific parameters around improvements on existing systems that I'm not aware, and if I'm wrong, please, I'm the first to say I'm not the expert, but I'm not aware that waivers have been granted for an entirely new system, because the waivers are meant to improve the delivery within the Medicare and the Medicaid system, and whether that's innovative or not, so on, is important. We didn't hear anything about another factor here that is important too, veterans. How do we take care of veterans who have through the Veterans Health System, which is completely different, and that is another consideration. And I will just say, in also of consideration, is that even if the Health and Human Services Secretary had the authority to do exactly what we're asking, it's important to remember that the Health and Human Services Secretary serves at the pleasure of the president. And so if the president is not interested in a certain way of doing things, then I'm fairly certain that the secretary would not be able to grant that authority. On the other hand, just the opposite, if the president wants to do that, I can almost guarantee you that you're going to have somebody in power to carry that out. So just there is a hierarchy. There are some challenges here, but my understanding, and based on not just what I've heard here today, but the research that we've done, is that absolutely we would require some changes in federal statute, and that we can agree to disagree on that if people wish to do that, but that is one of the challenges before us.
Thanks, Jim. Peter, before I come to you, I know, I want to make sure, Carmen, I want to pull you back in soon to just sort of reflect on some of the juxtaposition that we're talking through. And then I am certainly interested in getting Bill, one of the references that Carmen has in her presentation, you co-authored. We talked a little bit about some of these concepts when you presented or when we read the issues in Vermont and talking to former Governor Shumlin. So I'd love to invite you as well. So Peter, then Carmen, love to pull you back in, and then Bill, and then open it up to others. So Peter, go ahead.
Yeah, thank you very much. And thanks for both presentations. I want to agree a little with both and ask a question. It's framed by, I spent 2 years in Washington, including establishing the Center for Medicare and Medicaid Innovation. And as Carmen rightly notes, boy, do folks in the administration look at a non-exclusive list as non-exclusive. And the Obama administration pushed the envelope of where things could be stretched out and go beyond, and worked with, at that point, Secretary Sebelius to push that envelope in a number of areas. But it was still very much bounded by what the rules were, what needed to go to the Office of the Actuary, et cetera. But my core question I'd really be interested in hearing from both Carmen and Andy on. And Andy, hearing your perspective that really they're very prescriptive. And Carmen's take is, since it doesn't say you can't do this, hence you can. Yours is a little more limited, says here's what you can do. Under either of those takes, you're both saying it's the discretion of the secretary. And I want to go to Jim's point is, if it's the discretion of the secretary, that discretion changes with the new secretary. And for these different waivers, how long would it potentially last? Because most are, I think, I've seen 5 years as different periods. They are models, but we can't live at the whim of the next president, et cetera. So where does a waiver provide long-term certainty, or where are we at risk for a new secretary come in and saying, number one, I'm not going to wait till the end of the 5 year or whatever the boundaries are and shut it down sooner, as we know some presidents would like to do, or how far out could it be extended since a waiver is not a law? So that's my question to each of your takes. Assuming a waiver is possible, how far can it stretch because it's not forever? That's my question. And again, it's a great framings on both of these.
Carmen, yeah, please jump in.
So I'm trying to remember the other points that Jim also said, but to answer Peter's question about the issue that it's always going to be left up to the discretion of a political appointee is essentially what the idea is there. If we took that sentiment on everything, we'd never do anything that required any some discretionary authority ever. We wouldn't try to get our CalAIM waiver. We wouldn't have tried to do bridge to reform. So I think that's a little bit unfair to this system in particular, particularly with the overwhelming desire to do a unified financing system. And then on the kind of more what has happened in the past, I think our own experience with our own waivers and other states too, particularly Maryland, where they've been able to renew programs and to under the waiver authorities and to extend different types of programs that we have. I just find it, a little funny because, no one says this about CalAIM. Like, isn't it going to disappear because there's some requirements on duration? And then on the specific question about, is there a time limit? So it just says that the secretary has discretion over the duration and that the secretary can renew. Now, there's debate over whether or not that is specifically limited to 3 years or 5 years or 10 years. But, at the end of the day, some of these waivers actually have, it's just duration. And then the secretary decides what duration is. This is the great state of our federal healthcare law. But, I think, that's why I do like the framing of let's challenge ourselves to try to do this. And I think, it's a disservice to our state to just say, well, the Congress and the HHS, they hold all the strings, so we're just not even going to try. It just seems absurd for me for us to take that stance. And I think we do owe it to the people of the state of California to put something together and ask the federal government. And this is my point from earlier, is that we can build a program where and a state bill where we can give the state governing authority over such a program the flexibility to adjust to those changes that might happen on the federal level. And we shouldn't throw the baby out with the bathwater, if you will. Quickly on the VA question. So with the VA, we would leave the VA alone. It's just that veterans would be able to be in a unified financing program. We can't tell the federal government to stop providing VA care, but we can't. The same with IHS. So, I think those are just real things that we have to know, but that doesn't mean that we exclude veterans or Native American populations from a unified financing program that we have. And I will try to remember some of the other questions that Jim raised and maybe answer them in a little bit.
So,
Thank you, Carmen.
yeah, sorry.
No,
So,
please jump in.
Peter, let me answer your question by giving you a current event. So about 5 days before the Trump administration left office, the secretary approved a 10-year Section 1115 Medicaid waiver state of Texas, which effectively gave the state $3 billion a year in uncompensated care financing, which some of its safety net hospitals need because that state is not a Medicaid expansion state. So there were two remarkable things about this. One, it was a 10-year extension, and that was almost unprecedented in 1115. As an extension, Texas had previously had a demonstration, and the normal rule in the 1115 world is 5 years initially, and then either 3 or 5 years for an extension, depending on the nature of the extension and what populations are affected. So, so Texas got 10 from the previous administration. And as Jim pointed out, that secretary served at the pleasure of a different president. Okay, new president comes in, new secretary comes in. Texas waiver is rescinded in April. I won't go through all that it's occurred since then, but basically we're in federal court because the secretary's discretion to either grant a waiver or withdraw it is ultimately constrained by what the federal courts think is the secretary's reading of the language that we all just went through. They have the final say. So I don't know how this is going to play out. We'll see. But the takeaway is waivers are limited in time, whether it's 3, 5, 10, we'll see. The second point is the discretion of the secretary is subject to challenge by the federal courts, in this case by Texas, who wants to keep its waiver in place. And in the case of Becerra v. Gresham, that, as Carmen mentioned, by the people in Arkansas who didn't want to get thrown off the program through the imposition of work requirements. So it's not, to me personally, not a pathway to sustainable long-term funding to undergird a universal financing system.
Thanks, Andy. Don, I see your hand up. I want to invite Bill, if you want to jump in and kind of reflect on what you've heard and share any additional thoughts from your considerations in Vermont.
When we did the study for Vermont, we actually had to look into this question. When we talked to some attorney in this field of practice, as well as contacted some people at that time I knew in Washington. And the conclusion came back to us is this is very fuzzy and unclear. There may be a way to move forward, but it would be much more clear if new legislation could be introduced to permit Vermont to do it and then get the fund transferred to Vermont. And so that's why former Governor Shumlin called President Obama, officially asking Obama to introduce legislation. And then Obama thought about it and said he did not think that would be on his priority list. However, the good news is Vermont still decided to go ahead because it was unclear, and they thought there may be some legal way to, including getting the secretary to take some action. And that's all I know, how Vermont handled it.
That was very helpful, Bill, real life experience. I liked that you said fuzzy and not clear on the one hand, but didn't close the door and they decided to pursue it nonetheless. And then legislation might be cleaner, if you will. But okay, Don, jump in, please.
You know, I was going to make a point that I think Andy made, which is that we need to think about the courts, not just to what presidents are willing to do. When we look at questions about the expansiveness or lack of expansiveness of things like 1115 waivers. And we certainly have a lot of examples of that in the Trump administration. There were a lot of tests to the secretary's authority and to some of the other guardrails that are in place that limit a state's ability, the CMS's ability to approve state requests to make changes to their Medicaid programs. So, you know, that's an important consideration when we look into all of this, obviously. The question that I had, though, for Andy, really two questions. One is, I didn't, and I may have missed it, but I didn't hear you talk about 1332 authority. And I'm wondering if you have thoughts about that. There was a time when a lot of people were looking to 1332 authority as one of the real opportunities. I know part of the impetus for 1332 when the Affordable Care Act was passed was progressive states that were hoping to use 1332 authority to do exactly what this group is talking about. So Carmen talked a little bit about it, but I wanted to get your read on it as well. And the other thing, and this is something of a long shot, but you know, when the Affordable Care Act passed, CMMI, there was authority granted to the secretary through CMMI that was quite broad, that essentially allowed broad discretion for demonstration projects, and then the secretary broad discretion to adopt policies that were proven effective by those demonstrations. And just wondering whether there is a potential path through demonstration to get at least part of the way that folks are trying to go here.
Well, John, thank you for the questions. The reason that I didn't speak to 1332 authority is because I try to confine myself to talking about things that I know something about. And the other reason is that we have on the commission probably one of the nation's leading experts on 1332 authority. So I'm definitely not going to try to opine in that circumstance. You know, what little I know about 1332, it just does not implicate Medicare and Medicaid financing. I just don't think you can, as a secretary, use that authority to change the financing rules for the trust funds or the matching rules for Medicaid. And I'm happy to be corrected by someone who knows more about it. I do know enough about 1332 to know that the model testing notion was, if a model works, right, then the secretary can go ahead and essentially mandate it both in Medicare and Medicaid. If that delivery system and reimbursement model turns out to work, doesn't cost more, improves quality, et cetera, right? Okay, again, to me, that's not about financing. That's not about moving federal dollars into a unified financing structure in one state.
Before we go to Richard Pan, anybody want to jump in on 1332? You know, Carmen, you covered it a little bit.
Yeah, I'll just add with 1332. So 1332, I mean, it's new. It's relatively new, and a lot of and many of you know, like many of the waivers that have been approved are all reinsurance waivers, and no one has really tried to engage with this coordinated waiver process. So I think it is something that we can use to try to expand on some of the waiver authorities. You know, we can use waivers that exist already. You know, what we talked about, a lot of them. We haven't really talked about 1915 freedom of choice waivers, or trying to get the state program to administer Medicare benefits. You know, I think those are really interesting questions that we can try to put into a 1332 waiver process, and maybe that the 1332 waiver process, because, you know, again, no one has tried to engage beyond the ACA waiver authorities under 1332, the specific ones related to ACA programs. So 1332 could potentially give us some, the secretary, you know, I would argue, and again, you know, it is untested, but I think we can test it, and I think California, we've done it before in so many things, particularly during the Trump administration. The you know, our state has been out there trying to push the envelope in terms of what we can do as a state to make sure that our residents get the benefits that we think that they need and deserve. So I think we should try to push the interpretive interpretation of 1332 to potentially answer the question about duration. Like, can we renew other types of waivers within the coordinated waiver process? Can we, you know, can we build a program around this? You know, it is something to say that you know, Senator Sanders introduced the bill, as Don alluded to, the 1332 waiver as a mechanism to try to get to state single payer. Let's test that out. And I think, you know, just to put a little bit of a point that I think we've kind of been talking about, but I think I want to challenge ourselves when we're asking about transfer of funds, because really I want us to say, how do we administer Medicare and Medicaid? We don't necessarily need, you know, can the state program administer the benefits on behalf of CMS? Not necessarily, you know, is it a matter of, you know, the state fronting reimbursements to providers and then trying to seek to seek that payment out from Medicare later? So is it really, you know, which is why the shared savings program authorities are really interesting, because that's a different type of system that we could potentially use unified financing under to kind of, you know, let's not be you know, let's agree that we'll need to deal with CMS. It's not like we're asking the feds, and we shouldn't expect the feds to just hand over a blank check with a lot of money with no strings attached. We shouldn't. And I think, you know, I think that's really what I hope that we get out of this, is that, you know, we should try to think of new ways to put together a program, and that we shouldn't wait on Congress, you know, or the president or the courts to figure it out for us, because, you know, they're not going to figure it out if we never ask them. And I think, you know, I think we should, you know, as a lawyer, I think I advise the state of California to take that risk. You know, we're, you know, if we were 100% sure that we would win, like, we'll never be 100% sure that we'll win. But, you know, we have an argument, a decent argument that we can make that's untested, that we should go and try to seek.
Thanks, Carmen. I see, Richard, we're going to go to you, then Anthony, and then Michelle. I'm going to put you on the spot to talk as the head of our Medicaid program and DHCS, and the active work on CalAIM as a waiver, building on decades of waivers before. Just your thoughts on some of the waiver initiatives and what it is we can't afford to lose in what we're doing with waivers here in California. But Senator Pan, go ahead, please.
Thank you, Secretary Ghali, and really appreciate this discussion. A couple of observations first. As a, you know, I'll tell you, as a Medicaid provider, as well as a legislator who, you know, oversees the Medicaid program, I would make note that at least in the time I've been in the legislature and even before I was in the legislature, the state has shown actually an increasing reluctance to actually directly administer a program. In other words, they contract it out to health plan. You see more and more people being moved to a managed care plan. So I just, we need to acknowledge that if the state wants to reverse course, I'd love to have that discussion about that. So, but that's a historical observation. And in fact, with CalAIM, we're going to be moving more into managed care plans to actually administer the state, again, not wanting to directly administer. So just keep that in mind. So if we're looking at unified financing, we're looking at money coming to the state and then the state then contracting out, or is the state actually deciding it really wants to directly administer? The other observation I would also make is that, for example, we talked about CalAIM. I would make note that the 8 waivers we've gotten, having been through a few waiver cycles, I mean, they are temporary. And of course, there's tremendous negotiation. We're very disappointed the previous cycle with 1115 and how much the feds under the Obama administration, we're not talking Trump, under the Obama administration was willing to allow California to have under the I guess the budget, you can't spend more than you were supposed to provisions. So what the state proposed had to shrink considerably. So just again, keep that in mind. And then of course, that's why this waiver cycle, as we're doing CalAIM is actually not under 1115. It's under 1915B. So, we've sort of said, well, there are certain limits that we can do 1115. We've done it for many waiver cycles, and I'm sure Anthony can comment on that too when he makes his remarks. But we've sort of shifted ground because the 1115 doesn't really give, we've I think run into some walls there on what we could actually try to do. So again, there's limits to the waiver process, and then I guess I would just say from a legislative standpoint, I appreciate the desire to experiment and do things, but when it comes to appropriations, and also frankly, as a Medi-Cal provider, I don't want to make promises to patients that I can't deliver, which means that if we're going to do this, unless there's we don't have to be definitive, but if it's as vague as it is now, and given the fact that we have experts here who said, look, there really isn't authority, I don't think it's appropriate for us to at least appropriate and assume that we're going to get the federal funds. So sure, we can put together a plan, but then we have to finance it with state funds or new state revenue, whatever. So, let's just be upfront with people about it. Like, maybe we're going to try for federal funds, but I don't think we can assume we're going to get them, given given what the current federal law is, unless the federal government actually does carry through. And again, trying to build this on an unstable, where it's at the discretion of the secretary. And that's definitely in the law, in the federal law. I mean, we have to be, again, careful what we promise people, right? We promise something and then we tell them, oh, guess what? New president, new secretary, we got to pull it back. Suddenly, you lose it, et cetera. When you make commitments to people, and that's something, by the way, it's guided our implementation of the ACA, it's guided our implementation of Covered California, other types of things being, it's not that everything has to be certain, but I think we want to be careful that we don't go around telling people, promising things that we can't deliver, or that at the whim of someone that we can't control, where they would have a major impact, right, that we couldn't make up for. So I think that's going to be really important, because otherwise we're going to lose the trust of the public in no time. So I guess the question I did have actually is that, it's not as big as Medicaid and Medicare, but talking about ACA, people get refundable tax credits, to do subsidies. In fact, appreciate the Biden administration expanded on that so that we don't have that cliff. And we worked hard in California to provide those additional subsidies as well. And I appreciate that, that was said that, well, VA, veterans can stay on VA. They can choose which one they want, Indian Health Service. For the Covered California plans, are we looking at, what authority are we looking at? Are we saying that we're writing off those refundable tax credits, which is fine, in which case we just have to finance it ourselves? Are we looking at trying to also tap into that stream of funds? And I'm not sure under what authority we could. So essentially we would write those off, but maybe someone can address that. I don't know whether Mr. Snyder has answer to that, or Ms. Komsky has an answer to that. So we're going to include or not exclude the tax credits we get, that we currently people are getting through for covered for essentially exchange plans covered California here in California.
I can answer that last question from Richard really quickly. So 1332 actually is very clear on this, that the state can get pass-through funds under Section 1332 on federal tax credits and subsidies. So that's actually like the easy question. We can get it and put it into a state program. And I think, on the question that you were asking about, like not promising something to folks that we can't deliver on and not appropriating on something that we can't deliver on, in AB 1400, one of the ways that we dealt with that is that, we don't, the program isn't implemented until it's fully funded. So, we could pass a bill, we could create a program, then go to the feds and then do the appropriations. I think that's, that's the order. We're not going to promise something and we're not going to appropriate money until we can figure out the federal piece. And I think that's one of the things that we can do with a bill. And I think, again, like building the alternatives within the system, because there are a lot of different ways that we can try to approach getting the federal share.
Any other opinions on so the tax credits? They'd estimate how much we get and say and the state claims it.
Yep, there's, other than reinsurance funds, there's actually, I think, Alaska and Hawaii and a couple other states, like Hawaii, I think they had a small business program, which they had a totally different small business subsidy program, and they just get all their small business tax credit put into that program. And it's calculated and done. There's actually, so 1332 has a section that says that funds can be passed through to the state.
Okay, well, be interesting. Want to look into that a little more.
Well, just if I could just very quickly, it is very clear that 1332 allows that to be approved, passing financial tests of budget neutrality. And Carmen went through the different financial neutrality tests, but then it would be looked at with that piece in the context of all the others. And the APTCs are in the neighborhood of, $8-9 billion, which Mark did a really nice pie chart. A relatively small portion of the whole dollars is in APTC, but 8 billion here, 8 billion there adds up to real money, as they say. So.
Great, thanks, Peter. Okay, Anthony, and then Michelle, and then Rupa, I see your hand up as well.
Yeah, I wanted, glad Peter chimed in because I want to share a little bit about our experience working with Peter on the 1332 waiver that California did explore. That Carmen was absolutely right. This is a totally new process, so we're all figuring it out. Most states have done reinsurance. California did try to explore a 1332 waiver, which was a very modest one, which was to allow undocumented Californians to buy into the exchange, and without subsidy, just allow them the access. And I think this gives this is instructive of both of the conversation we're having here, because I want to be clear that I'm glad we're having this conversation because it's important to be clear-eyed about the obstacles, not as an excuse for inaction, but to be really clear about, okay, if that's an obstacle, how do we address it? How do we get around it? How do we, how do we go forward, right? So I want to be really clear that that my interest is not to find an excuse to say, okay, we can't do this. My interest is what can we do to address the obstacles that we're facing? And so in the case of this relatively modest issue that we have, and my organization, Health Access, working on this broader Health for All campaign, said, how do we deal with this? And in fact, the issue of whether undocumented folks can buy into the exchange is actually one of those provisions of that is not waivable. And so what our theory was that the 1332 waiver allowed us but the parts that were waivable, we found that one of the things that we could potentially ask the California to do is to arrange with the plans to create mirror plans that then people could buy that were identical to the qualified health plans in the exchanges. And so now this also goes to another point that we're talking about, which is that we did pass legislation. We did Covered California did submit that waiver, and then it was withdrawn January 19th, 2017, because of the change in administrations federally. So we do need to be mindful of that as well. I guess my question to our two presenters, appreciating very much, is that, to Andy, I guess I would say, is there, is there some, you mentioned that there's just not authority to transfer dollars directly, but Carmen just mentioned this notion of having the state be the administrator of Medicaid and Medicare. And I wanted to see if you thought that was a viable workaround. And then for Carmen, what's the backup plan, right? Like that you've thought about in terms of if we get denied, does that mean then the whole, we don't go forward with the whole system? Or is there maybe some complexity, hopefully on the back end, that we're willing to live with, where we allow Medicare to do its own thing, or we do something in back end? I'd just be curious if you had thoughts with regard to that. The final point that I would just make is that we are very aware of these waiver constraints, and literally just yesterday, the Biden administration put out the new 1332 guidance for this. We were actually very active in advocating to have a more looser guardrails, especially on this issue of budget neutrality, because I do think that and unfortunately, the new guidance didn't go as far as we would like. One of the things in the current guidance, and I agree with Carmen that this is something that could be done administratively, but they didn't take our suggestion, was right now the budget neutrality actually counts against us if we enroll more people into coverage, people who are already eligible into coverage. This is, and I understand why they do it. They have this budget neutrality because they're trying to prevent some states with maybe not as enlightened leadership from doing bad things, but they have, at least at this current moment, they've undone some of the stuff of the prior administration, but they do still constrain some of the bluer, more innovative states from doing as much as we could. And I do think that that's some advocacy we can do right now. We don't have to wait for figuring out the perfect solution in this commission to be advocating with our federal friends that even the existing guidance is constraining to what California's ambitions. So thank you for allowing me to talk a little bit about our history of 5 years ago.
And thank you for that history, because I was involved in looking at that 1332 and I was concerned given the challenges we ran into.
Anthony, that was really helpful. It's good to hear and important. I really think your initial comment is where I hope we all go, is that these are hurdles. There is importance to understand what is possible and what isn't, but also understand how you maneuver through things, because that is, I think, what we all want to be, right? Change makers and agents of change in this space and many others. So Carmen and Andy, any comments, feedback on what Anthony just shared before we go on to Michelle?
Just a quick answer. I don't think either section 1402 or section 1115A authorizes the secretary to let the state of California or any other state administer the Medicare program for it. I'm not aware of any other waiver authority that would allow the secretary to do that. The secretary does, of course, use private insurers to administer the Medicare. I'm not aware that the secretary uses state government to do that. In the case of Medicaid, well, yeah, it's a federal state program. Medicaid can run, the state runs the Medicaid program within federal rules, but just the Medicaid program, not Medicare.
Yeah, you know, to answer Anthony's question, you know, I do think that, you know, looking at so the shared savings model and getting the state to essentially be a shared savings program it's a very intriguing proposition that we should look into in terms of administrating Medicare, and then on what would happen, I think, you know, if there was, you know, some level of rejection of a waiver from the feds, I think, you know, that's a question of, you know, how do we make it administratively as simple as possible for the people who are eligible for Medicare and Medicaid. You know, again, the ACA question is actually very, very, very much easier, other than the budgeting question, in terms of integrating all those programs into a state program. But with respect to Medicare and Medicaid, you know, the question is like, you know, can we take our Medicaid waivers to an extent possible that where we can integrate it as much as possible into a unified system, or is really the question that we're adding a whole bunch of people who aren't eligible for Medicaid benefits into the same program that we run. So, you know, the concept of, you know, undocumented adults aren't necessarily paid through the federal share, but they're still a part of the Medi-Cal program. So like, that's the same concept. Like, can we add everybody else who doesn't necessarily aren't necessarily eligible under the Medicaid program per se into the same program with the same name, with similar enrollment as Medicaid. So that's kind of, you know, it becomes an administrative question. And then, you know, how do we have, you know, potentially the question would be like, do we need to have some dual programming where people are able to enroll in Medicare? Does you know, does the state program participate in Medicare as, you know, as potentially, you know, a plan might participate in Medicare? That's kind of like the other options that are out there. But I think we should try the first option first before we start going down like what's plan B.
All right, thank you. Michelle, turn to you, and then Rupa, and I see your hand up too, Bob.
Great, so thank you for the presentations, and then the question on what waiver authorities we would want to maintain for Medicaid to further our goals in transforming Medi-Cal. I think critically, I would want to start with, we would want to ensure that people entitled to the traditional Medicaid benefits such as transportation continue to receive them, and that we protect and maintain the special coverage we have for certain populations such as seniors and persons with disabilities. So for example, we use waivers such as the 1915C to provide alternative services such as home and community-based alternatives to institutional care. So think about services for persons with developmental disabilities, assisted living, waiver, personal care services. So we want to make sure that we could protect and maintain those flexibilities. And then finally, as has already been discussed, I would highlight what we are seeking to do with CalAIM to add services such as housing navigation, housing support, the pre-release in-reach in some of our justice facilities that are a cost-effective alternative to some of our Medi-Cal services today. And we would want to maintain and protect these abilities as we work to redesign our health system. So just flagging that those are important tools that we have and would want to maintain those as we kind of continue these discussions.
Great, thanks, Michelle. And Richard, you identified it, and I think Michelle alludes to it. This is a blend of using the 1115 and the 1915 class, right? Not just B, but C, the addition of home and community-based service options here. I mean, there's a lot in play, and I think some of the roadblocks on 1115 that have popped up around budget neutrality and how that's calculated, as you mentioned, Anthony, I think is important. Carmen, your presentation addressed it. And then the 1915B route through managed care and thinking about actuarial soundness and some of those concepts. But I think one of the other big things, right, is they are 5 years and then you build on them. Like one of the things California's done, if you look at the history of our waivers, they actually come together nicely and have some building upon one another. CalAIM really takes a lot of what was done in this most recent waiver under the whole person care pilots and says, let's memorialize those, let's make them standard benefits where they can, and then grow them in some other areas. So, you know, to the point, it's not 5 years and done. The way California has done it is, yes, you have to renew it every 5 years, but they build upon each other and they do some of the really important things Michelle raised. Okay, Rupa, please jump in.
I just want to thank everyone for this great conversation and education around these complex topics. I just also want to zoom our focus into, while there are these potential obstacles, I'm with Carmen in thinking if it's not explicitly prohibited to, for the secretary, HHS secretary, to move these funds through a waiver, we should go for it. And the reason why is because of this historic moment we're in with this pandemic and the number of lives we've lost in the United States, which has now surpassed the 1918 flu pandemic. So we're at a moment where healthcare, the access to healthcare, equitable healthcare is on the minds of most people. And more and more people are encountering the healthcare system. There was someone who recently said on a Twitter feed, I'm glad I got COVID now because my deductible's been covered, as opposed to earlier in the year. So the fact that people in this country are thinking about that as opposed to their well-being is an indication of truly how broken our system is. And we know it, and everyone knows it. So I say we go for it in terms of advancing an opportunity right now to push on the limits of what those waivers actually mean. I would also want to just note California's leader status in culture and social movements, so that if we were to apply for this and it wasn't explicitly prohibited or not explicitly authorized, it would give an opportunity for the federal government to respond and to push this whole issue nationwide. And that might change the dynamic of what we're seeing. So the bolder and more courageous we are in the framing that we deliver, the more we can push this agenda nationally. I also want to say that outside of federal waivers, so the non-federal funding stream, so California is, I think our GDP is around 2.3 or $2.9 trillion, which places us between Germany and the UK if we were a separate nation. So what can we do with non-federal funding streams, and how can we use our propositions and our financial plan to curry some political favor around perhaps not implementing some of those things and getting some support from the federal level to push the agenda on waivers. And the last thing I would say, because the UN is meeting right now around the food system, is I would love to see in our work how we can, in addition to the important programs that Michelle just mentioned with Medicaid, how we can really incorporate food access, farming and food access to every Californian, to have access to organic, healthy food. As we've seen with the hospitalizations from COVID, 67% of the people who've been hospitalized with severe COVID have some sort of nutritional derangement. And so how can we get ahead of this in California and create a much better food system that's integrated with our health system? And I would love to see that in our design. Thank you. Oh wait, Carmen, if you could comment on your thoughts on the non-federal funding streams, because I saw you briefly mention that in your report, but I didn't. Can you give us some more?
Yeah, sure. Thanks for, I think, I think this is the non-federal funding stream question, and also just looking at what we can do in terms of savings in a unified financing system is really important to this discussion of sustainable financing, because, we're all worried about, okay, like what happens when we don't get to the federal share, but like, if we create a program in a way where we can capture enough savings, we're building that cushion. And I think that's really important. And, trying to get the savings as much as possible is really important. And then in terms of non-federal financing, again, I think it's really important for us to also think about that question and to present that question. We have members of the legislature here, and I know that you all always ask this question, and I want to answer that question for you. What are the non-federal financing sources? And I think we need to do that because there's a lot of we can call them excuses, we can call whatever they may be, and hurdles. Let's try to take another one of those down. Let's try to figure out some of these questions. And I think for non-federal financing, we can look at things like corporate taxes, gross receipts taxes. Maybe we can look at payroll taxes and income, wealth taxes that are out there. But I think, having that kind of menu of options to present to the legislature is really important, and to the governor, because, we have to start all of these conversations. If we don't start these conversations and, just wait for the courts or the Congress to act, or wait till the next administration comes until there's some clear vision from the feds, like we're going to be waiting forever. Like we all see what's happening in Congress right now. Like I don't think I trust them to move quickly. So let's try to move the ball as far forward as we can before, on our turf right now. So I think, again, trying to create that kind of combination of savings under our program that we develop. And I think importantly, trying to reduce the prices, do direct negotiations with payers, try to get all the competition, I think as Governor Shumlin said before, let's try to build a program where we outcompete everyone. So everybody comes into our program. I think it's a goal that we should strive for. And I understand a lot of you are trying to figure out like what are the roadblocks, but I think we can't scare ourselves out of trying to do this. We saw those statistics from the community engagement program survey. We have to try something.
Okay, Carmen, I know I think it's some of the commissioners got to jump in about 10 minutes. We have about 15 minutes more of our conversation. I'm going to wrap us up, and I want to make sure, because this has been terrific, make sure that we give some time to the public. So if you're a commissioner and you want to jump in, especially with a brief comment or a question, rather than have Carmen and Andy answer the questions, because I do think, Andy, you might have to drop soon. I want to get them out so the public hears our questions, we understand, and then we'll try to circle back and find a way to get to them. So Carmen and Andy, really appreciate you guys diving in and answering on the spot, but let's see what the questions are, if they are, and we'll catalog them. And if we have time to get back to them, we will. But I want to make sure we give commissioners. So throw up your hand if you haven't already and you want to jump into the conversation. We'll go to you, Bob, and then Ginny, and then Jim.
Thanks, Mark. Boy, what a illuminating and at moments sobering conversation, but one we need to walk through for sure. I'm struck by the tension we'll have to manage. On the one hand, can we be fearless and creative and daring in terms of this particular question today, waiver authority to get there, but Also, Commissioner Pan's concern that we not build something transformational on a house of sand that could come tumbling down politically. So I thank you for illuminating this part of the conversation. My question is probably for Andy. Andy, I'm struck by the irony, and help me. It's a naive question. I heard you say that there's waiver authority for the federal government to designate a private insurer as an administrator, but not a state. Did I hear that right? So that private insurance companies have greater ability and capacity to administer these federal health funds than a state does.
That's what I said. I'm pretty sure I'm right. And the reason for it goes a long way back. This is a 1960s era program, Bob, right? So at the time, providers thought the best way to protect themselves from the federal government was to interpose private intermediaries, private insurers. There's been a long history, but the structure is still in place. At least those two waiver authorities are reviewed. There's no authority for the secretary to change that.
Well, thank you, Andy, for clearing that up. And that may be the most infuriating thing I've heard today. Thank you.
Thanks, Bob. Jenny?
I was going to pass it because it was going to be for Andy, but why don't we go ahead with Commissioner Wood first?
Okay, we'll come back to you afterwards. Go for it, Jim.
Yeah, thank you. And I just a comment, and because this is a fascinating discussion. You know, on the one hand, we've had hearings where we've heard experts who have said what Andy has said. We've also had hearings where we've heard from proponents of SB 562 and the previous iteration on how we could get there. And I hope, and my concern is that my concern is that this is obviously complicated, and we have two very different opinions, and we also have federal courts that are out there as well. So my hope is that we as a commission could agree that we really don't know exactly at this point, or we may have to go in a different direction. I don't really know. But what I hope is, what I don't want to do is to tell people, yes, we're going to do this, and we can do it because of this, when we don't know for sure. And so part of my role, I believe, and regardless of my beliefs, I want to see everybody get healthcare. I want it to be high quality, affordable, accessible. I want all of that. But I want to be realistic with people about what we do know and what we don't know, because I don't want people's hopes to be so high that we can't deliver at the end, and so high that we can't sustain it without financing. If we don't get the federal waivers, if we don't get federal resources, and I really need to understand how we get there as a state to fund this. What hasn't been discussed, and I hope will be discussed at some point, is around affordability. In this state today, the cost of healthcare is rising at twice the rate of inflation. And everybody in the healthcare industry points at one another as being the problem. And trust me, I have been fighting this battle. Secretary Ghali has been fighting this battle alongside me, trying to get somewhere around affordability. Affordability is fundamental to sustain a system. And that is also has to be a critical part of the conversation going forward. So I appreciate both perspectives. I hope we can leave realistic, and partly in what I take away from this, we don't know for certain. And I don't want any of us to go out and say absolutely categorically, yes, we can, we absolutely know this, or no, we can't, we absolutely don't, because I don't really believe we have all of that information.
Jim, thanks. You're helping me think of the way to wrap this up, and that's helpful. Andy, I fear that you're going to have to jump off before we get through Richard and Jenny and some other comments. So let me just say on behalf of the entire commission, thank you to you and you, Carmen, for really tremendous presentations, and appreciate your time and energy in educating us, giving us your opinion, but also helping us see some of the opportunities here for California as well. Richard Scheffler, please jump in, and then Jenny, I'm going to come back to you and see if you want to. No pressure, but the floor is yours after Richard.
I'll try to be very brief too. So I'm in the camp of pushing the envelope and pushing this forward and asking the questions at the federal level and seeing what happens. It may take more than one try, but we need to start to try. So I'm behind Carmen's way of thinking about it. You need to ask and find out why they said no and what we can do to make them say yes. Having said that, we still have another problem that we haven't discussed, and that is the self-insured plans that are covered under ERISA, which have a different set of legislative problems. And it turns out, as you well know, that they're probably 40+% of the healthcare spending in California. And without their participation and dollars in this, even if we got the federal waivers, and I'm, as I said, in the camp of pushing it, without some participation from this group or some changes in federal law about what the ERISA plans could do, we would still fall short of having the financing. So I don't want to make things worse, but I want to get everything out on the table so we don't miss this issue, because people know about it, and it's an important one. Andy, I still see your face there, and Carmen, so maybe you can take a shot at answering it. Sorry, Mark, to put it back to them, but I'm really curious about their view about ERISA.
Don't be sorry.
So I do have to leave at 6:30, and I was just waiting to squeeze the very last minute out. Thank you for your comments. So I know almost nothing about employer-based financing and the tax code and how that works. But I'm pretty confident in saying you need a federal statutory change. Just like I'm really confident in saying you need a federal statutory change on Medicare and Medicaid to move toward a true unified financing system. I think if you can get it, in the long run, you're much better off because it's a much more stable solution than being at the mercy of who's in the secretary's position at any given time. So thank you for the conversation. And I'll see you guys next Tuesday, right? Oh, yeah, okay, thank you.
Thanks, Andy.
I actually, I originally was an employment lawyer, so I do know something about ERISA. And I think, I think we're always asking the wrong question when we ask about ERISA, because we're assuming that we need to capture directly employer contributions. We don't. This is where the non-federal financing question really comes into play here, because we're not necessarily, we don't have to ask for a pay-to-play program in order to capture the non-federal financing. So that's one question. That's how, if you don't implicate ERISA with respect to pay-to-play, that's how you address that. And then kind of, and there's, we're in the Ninth Circuit, which has the best precedent for ERISA preemption analysis, the SF. The Healthy San Francisco program, there's the Golden Gate Restaurant Association decision. And then I guess the other big ERISA point is, again, what Governor Shumlin said. You don't directly regulate in the bill that you pass. You don't directly regulate ERISA plans. You regulate insurance as much as you can. Potentially you can have a non-duplication of services provision that applies to all insurance, which the state has authority It's saved under the ERISA preemption statute. And then, you know, as a fail-safe, you outcompete the other plans so that employers don't want to provide a plan that isn't our program. And I think that's the 1 minute answer to ERISA.
Thanks, Carmen and Richard. I think we will. I tried to sneak in ERISA in my comments very early in the hopes that we wouldn't go down the rabbit hole here, because this was a lot to capture in a day. So we will certainly have to contend with other beasts besides the federal funding issue. But thank you for keeping this part brief. Sarah, your hand's up, then Sandra, and then I'm going to do the unthinkable and cut us off and help us move to public comment. So Sarah, go ahead, please.
I was just going to say thank you to Commissioner Scheffler for raising the ERISA issue. I know much more about ERISA than I do about Medicaid and Medicare, and think there's a very rich discussion. I agree with Carmen. There are a lot of creative ways we can get around it without changing statute at the federal level. A lot of this work has been done. I think a key question is the tax break, is the tax expenditure for health coverage that employers get at the federal level. It's huge. I mean, it's our largest tax expenditure at the federal level. If California is no longer availing ourselves of that, I assume that's a savings to the federal government and the state. And so that frees up money. And so I think there's either leverage or opportunity on that. And so just would love to have a session looking at tax implications, tax structure, and ERISA. I love any ERISA conversation. I know no one else does, but.
All right, we will. It's been on the list. It's on the list. Sandra, somehow now I find you with the final commissioner word. Do it well, and then I'll try to wrap us up.
Yeah, Mark, I'll just be very brief because I know we're late in the day. I did want to appreciate the conversation we had this afternoon, Carmen and Andy. I thought it was incredibly helpful. I just wanted to raise my hand on Healthy San Francisco and the ERISA issue. I chaired that effort. And I think minimally it would be, I know your goal is not to get into ERISA today, rightly so, but it might be worth just, and by the way, that ERISA question was a narrow question on Healthy San Francisco, but we did prevail. And so I do think it's worth a little mini case study at some point by somebody on that issue, on the ERISA issue, which I think would be instructive to the commission. So really a great session today. Thank you.
Yeah. When I saw Sarah and Sandra's hand go up right after Richard's, I knew I wasn't going to be successful to keep us out of the ERISA lane, but really appreciate everyone's comments. Let me try to wrap us up in 2 minutes. First, really a tremendous conversation. Appreciated the presentations. Carmen and Andy, I think you came at it at very different ways, and it frankly was super successful in getting us to struggle with some of the challenges. And rather than have just one point of view presented and everybody say, oh, I love it or hate it, I think we talked about the gray in a really successful way together today. You know, I never am going to push us to vote in this session when we're talking, but you saw some hands go up. Some people said, let's go for it. Let's really push the envelope. You heard some other people say, let's ask a few more questions. Let's try to understand what it means to push the envelope. I've been thinking a lot about, you know, how does this session fit into the final report? And today is a really good example of where, as we learn more about what permissions, authorities exist, what are the questions, where do we push? I think it's, we're left to, if we discover this, then we would maybe do it this way. If we discover something different, we might do it that way, and really share a bunch of different pathways, because in reality, it sounds like it might be a blend of some things that we have to do. And I think that there's some terrific substrate here to really push us, and I'll ask the consultants in our work of trying to summarize. This one's not an easy one to summarize because I do think there's a lot of different roads that could come out of it. But I don't want to fail to acknowledge that those who voted said, push the envelope. Let's see something that's different and move forward. And Richard, you get the 2 thumbs up a couple times on this, so thanks. All right, I know that we could have stayed here and stayed on this for a much longer amount of time, but let's go to you, Karen. But before we do, just because we often wrap right at the end and people want to leave, I keep forgetting to preview what's coming up. You know, this was a busy 2 weeks. Today was the second meeting this week of, not meeting, but convening that's really addressing the commission's work. We have another conversation next week. We'll have a couple of more of our commissioners, Antonia and Bob are invited to do some of the presenting on looking at the structural racism, equity in the healthcare delivery system. I'm really looking forward on how this builds on conversations that we've had already, the webinar earlier on community engagement, and some of the things that we discussed on workforce and where we want to go. I know they'll be terrific in presenting. And then we'll also have a chance to talk about the priorities, goals, and values survey that you all have been moving on and engaging on, and have some public discussion there. And then not shortly after next week's meeting, we have October 11th, where I'm busy planning and getting us into a conversation about payments, which will sort of build on some of what we talked about today. So I'm looking forward to those 2 sessions. I know all of you are. And let me just wrap up my comments by again thanking you, Carmen and Andy, for really leading us through a terrific conversation. So with that, Karen, do you mind facilitating the public comment?
Not at all. Thank you, Secretary Galley. We are now going to move into public comment. Before we adjourn, we will open up the chat feature for written public comment. And as always, you can email your comments to healthyca4all@chhs.ca.gov. We'll now allow members of the public to use the virtual hand raise feature to queue up to also speak verbally. For verbal speakers, please know that you need to contain your remarks to 60 seconds, and then we'll need to move on to allow as many comments as possible. We will also allow for the 3 top folks in the queue. We'll be inviting you to also turn on your video shortly before you speak. And please state your full name and any affiliation that's relevant to this conversation. And with that, we will start with Henry Abrams. Please go ahead.
Thank you. Dr. Abrams from Physicians for a National Health Program and the Healthy California Now Coalition. The description today involves an enormous amount of complexity. And I think that we want to build a system that's secure and sustainable. And therefore, I think that a lot of attention needs to be given to simplicity for patients, for providers, for administrators, and for legislators. And I'm really interested in the commission's comments or looking into Representative Khanna's HR 3775, the State-Based Universal Healthcare Act, which is a piece of legislation that has a long way to go, but would consolidate funding streams and also lower any barriers posed by ERISA preemption. So
thank you, Dr. Abrams.
Be included in your deliberations.
Thank you very much. Jeffrey Tartagia, you're next.
Well, I'm going to try. This is Jeff Tartagia, an advocate, HCA, and various other organizations. The 2 things of the last 2 monthly meetings is, where is the patient? So I appreciated the previous individual speaking about how you do it. I can speak to say to Dr. Galway that when the master plan on aging, the recommendations you came up I don't see you in December, much less February, coming up with more than 15 recommendations of how do we go for a universal paying program. This year, I was involved with changing over as being a disabled individual for 10 years, and I started in March asking to see a urologist. I have yet to see them. The appointment keeps getting changed. So not only is it important that you look at the universal program, but also the timeliness. And you spoke about the workforce. And I remember with Dr. Pan speaking about, when the ACA, what was done with there, what you did with Riverside to make that work out.
Thank you, sir.
That's my
We've got to
comment.
move on. Thank you so much. Leah Schwinn, you're next.
I'd like to say two things. I'd like to stress what Commissioner Comsty said about savings. Savings is a very important part of financing. And in terms of sustainability, our for-profit system has shown us that it is not sustainable because of the increases in premiums. And all of the studies about savings using a single payer system have shown savings for the first year and increasing savings as the years go on. The other point I want to make is that although tax is a dirty word in California, when people understand that they would not be paying premiums, they would be paying a tax that would be much smaller than their premium, then most people would be willing to pay a tax, a small tax, to make up the difference in funding that we need. So we need to count savings, we need to count a small tax, and then whatever money we can get from the federal government. Thank you. I'm sorry, I forgot to say I'm healthcare for all.
Thank you very much. Donald O'Sullivan, you're next.
Yeah, thank you very much. I learned a lot today. I was very informative. And I'm hoping that there aren't meetings that are held in private that we could be at learning more, even more, because I think all of the meetings should be public in the public domain. I just want to say that, yes, it's been complicated. And I believe that your job is to report to the governor the single payer options and how that could be achieved. If you do it, or when you do it, you will end on insurance in the state, and single payer won't end systemic racism, but it will make it easier to use the healthcare system to combat racial disparities. And I checked the other countries, Russia, Canada, Britain, Germany, etc. Canada's universal, publicly funded healthcare system known as Medicare is a source of national pride and a model of universal health coverage.
Thank you, Mr. O'Sullivan.
Thank you.
Thank you very much. Peter Shapiro, you're next.
First of all, I feel like I've been in a law school seminar today. I'm not a lawyer, but I do think that this is as much about politics as it is about what the law requires or doesn't require. And politics is all about pushing the envelope, and I hope people bear that in mind. So much depends on how much we're willing to demand, how much we're willing to fight for it. I do want to reiterate what Leah Schwinn just said about savings. That is a huge picture of the puzzle. It needs to be discussed. Right now, I think public employees in California are being, there's a $200 billion plus pension liability that's unfunded right now. This is an issue that instituting a single payer plan in the state would directly address. It would save a hell of a lot of money for a lot of cities and communities that are strapped for cash right now. And I hope our legislative representatives will take that into consideration as well.
Thank you. Chris Hofiditz, you're next.
Yes, hi, my name is Chris, and thank you for providing me some time to speak today. I want to start with a question, and it is whether it is time to begin to make some decisions to keep us on track for completing our timeline and providing information to the governor. Commissioner Rupa Maria suggests that we make some bold steps. I suggest that the commission adopt Assembly Bill 1400 as the roadmap to move ahead. It would serve to give specific direction for the commission to move ahead. And the first support column would be to design an interactive calculator with various options for financing AB 1400 and how much each financing mechanism would raise. And debate whether or not they're possible or not, of course. Commissioner Comsty suggests this would make it easy for the public and legislators alike to weigh the pros and cons of the various proposed financing options.
Thank you, sir.
Okay.
Thank you. Appreciate you honoring that. Bill Honigman, you're up next.
Yes, thank you. Bill Honigman, retired emergency room physician from Orange County. I'm concerned, especially about both the needs of our communities and financing the resources to meet those needs, because when those needs are not met on the front end with attention to preventive care and culturally sensitive, untiered and unimpeded care, we all end up paying for it anyway in more ER visits, personal bankruptcies, homelessness, and preventable pain, suffering, and untimely deaths. Commercial interests, in particular risk-bearing intermediaries like health insurance underwriters, bring no resources to provide this front-end care. In fact, they misdirect care to demographics that they consider more marketable, not to our communities in need. And pharmaceutical companies are just as bad or even worse in this regard. COVID-19 has shown us that universal health care, such as we've seen with openly accessible, free at point of service vaccines, has positioned California as a leader among the states in overall performance now late in the pandemic. But we've failed in terms of universal testing, contact tracing, and in providing the comprehensive care for other conditions that put us all at risk. Thank you.
Thank you, Dr. Honigman. Isabel Story, you're next.
Yes, hi. So I'm Isabel Story. I'm with California Indivisible. I want to thank the commission for the work it's doing, but I think the continued ignoring of AB 1400 is really mystifying and a mistake. This bill provides a blueprint for a healthcare system that would completely fulfill the mission of this commission. So instead of ignoring this legislation, I think the commission should study it and discuss it. We really haven't received a concrete reason why the commission refuses to consider this bill. I've heard that there was sensitivity on this topic, and I'm really wondering what this sensitivity is, who is opposing this, and why. The commission is endeavoring in many ways to be transparent. However, on this issue, there is no transparency.
Thank you, Ms. Story.
Okay, thank you.
Thank you. Richard Gallo, you're next.
They just called you. Hello, can you hear me?
Yes, sir.
Yes, I just sent my comments on email, but I just wanted to say for the commissioners to please go by AB 1400 instead of stalling this. Healthcare is needed now. I'm a mental health worker, and we serve patients in the 5150 unit. The concerns that I have, those are uninsured. When we let them go, they can't seek help or get medication because they're uninsured. This is not acceptable in today's society. They have the right to have access to health care. Please proceed with AB 1400. Thank you.
Thank you. Nasim Nuri, you're next.
Hi, thank you very much. I'm a member of the Santa Clara County Single Payer Coalition and the Santa Clara County Green Party. I really want to urge every commissioner who today raised concerns about implementing a single payer, about raising people's hopes, or all the other what ifs, to please recognize the urgency in adopting a single payer system such as AB 1400 to address this crushing impact of healthcare inadequacies and inequities in California. Commissioner Wright's comment that 80% of us don't deal with healthcare system on a regular basis is really not the reality that people live in. The overwhelming majority of people, especially in our marginalized communities, deal with healthcare inequity and access every single day. Every woman who's on birth control, every diabetic, and that's 13% of US adults, every person with heart disease, 1 out of 4 deaths or caused by heart disease, every person that's rationing their medication, every young woman of color who's
Thank you.
pregnant and is looking at a terrible outcome, they all need AB 1400 and a single payer system, and they deal with healthcare inequities
Thank you.
every single day. Thank you.
Thank you. Marie Lopez, you're next.
Great, thank you. So we need to remember that California will be a leader in the country when we pass single payer legislation. We won't know for sure what the federal government will say about a single payer program until we try. But we cannot just apply for waivers until we have enacted legislation that sets out those terms of the program and authorizes a state to apply for a waiver. Single payer legislation is the first step, not the last step, to creating a unified finance system that allows all Californians equitable access to health care. The legislation would not need to go into effect until federal funding is secured. So California has gone through this exact process in the past. California passed bills to establish the Breach Reform Program, as mentioned by Carmen, in 2009, contingent on and in anticipation of needing to apply for Medicaid innovation waivers. The process of securing federal funds for a new way of providing Medicaid and Medicare benefits is not a mystery. Thank you.
Thank you. Maria Bien, you're next.
Hi, my name is Maria Bien. I'm co-chair of Sonoma County's Healthcare for All Working Group. The dialogue we heard earlier between Commissioners Ross and Maria made me want to quote Barry Goldwater, of all people, who said, "Moderation in pursuit of justice is no virtue." Healthcare justice is hugely important for us as individuals and as a society. So yes, I urge the commissioners to use your expertise to develop reform plans that are not only bold, but achievable. But let's remember, we already know universal healthcare can be achievable and affordable, despite the vested interests who currently have US healthcare in a stranglehold. They would have us believe otherwise. We just have to look to the many countries who've done what we're repeatedly told cannot be achieved. Commissioner Pan talked about losing the trust of the public. If you want to lose the public trust, keep focusing on obstacles, some of them purely hypothetical, while people are dying. Californians would benefit more from more zealotry and less moderation from this commission. Thank you.
Thank you. C.T. Weber, you're next.
Yes, C.T. Weber. I'm a member of the CARA Legislative Committee, Sacramento Central Labor Council, and member of Peace and Freedom Party. We live in a system that actually has several healthcare systems. We have not only the fragmented private system built around insurance companies, but we also have a single payer system with Medicare. We also have socialized medicine with our VA and the military and so forth. So I guess the myth I want to leave everybody with is this is not socialized medicine. We have private doctors, it would have private nurses, private hospitals, private clinics, private pharmaceutical companies, even the manufacture of medical would be private. Everything would be private for profit. The current system that we're using that we're so upset with is the one that wastes 25 to 35% of the cost of medical care is the overhead, the insurance companies, the profit, the administrative costs of contacting all the various insurance companies. And did you say time? Okay.
Yeah, I'm afraid your time is up. Thank you, sir.
Thank you.
Bryn O'Neill, you're next.
Hi, Bryn O'Neill, CNA. So I'm team Push the Envelope. As several commissioners shared, federal healthcare program waivers, they aren't new and they aren't new for California. States use waivers to redirect Medicaid funds, to expand program benefits, change service delivery, and create new types of provider payment methods. Medicare innovation and demonstration waivers allow changes to methods of payment, reimbursement, and delivery to increase the efficiency and economy of health services. We don't need blank checks from the feds. We can be creative about administration. Federal statutes specifically encourage innovations that implement systems of all-payer payment reform or integrate Medicare and Medicaid care for dual-eligible individuals. Section 1332 lets state receive ACA funds directly for health programs. States like Hawaii and Minnesota have substituted federal ACA coverage with a state program. Federal law was designed to let states try new things to get better health coverage to more people for cheaper. We can do all of
Thank you,
that with
Zennia.
single payer.
Thank you very much. Ruth Carter, you're next.
Hi, thank you for a very informative session. It was also enlightening to see the results of the surveys that were presented at Tuesday's webinar. My name is Ruth Carter, and I'm the chair of the California Democratic Party Senior Caucus. And from a senior's perspective, many of the same requests for respect and culturally sensitive care is definitely needed also. As a parent and grandparent of middle-class family members, they have exactly the same issues around accessibility of services and affordability. One of the things that concerns me about today's session was that I heard some commissioners look at only the possible problems with a single payer system rather than looking at ways that could make it work. I would hope that having the objective of universal, guaranteed, affordable healthcare as a goal would obviate the statements that all begin with yes, but. How about start with yes? And let's see how we can find a way to make this work. Thank you.
Ms. Carter. Philip Kim, you're next. And looking at the time, I believe you're our last verbal speaker. So I would just recommend that others make sure that they provide their comments in chat in the last minute here. Philip, please go ahead.
Okay, thank you. Hi, everyone. My name is Philip Kim with the California Nurses Association. I'm in Sacramento. I think it's clear from Carmen's citations of existing laws that we do not need Congress to change federal law to be able to establish single payer in California. Current federal law includes processes to waive Medicare, Medicaid, and ACA program requirements if a state has a plan to offer care under those programs in new or better ways. And guess what? AB 1400 is an already drafted plan that can provide better care for less money for people eligible for federal health care programs. As Commissioner Comsty explained, each federal waiver authority has its own requirements, and ACA Section 1332 lets a state go through a unified waiver application process. Let's use that. Senator Bernie Sanders, go Bernie, introduced this waiver to the ACA with the goal of helping states enact single-payer programs. To qualify, California needs to pass a bill that fits the requirements outlined in existing federal law and then apply for waivers. Californians will not accept excuses by commissioners or politicians trying to blame Congress for their own actions. So please do the right thing. Thanks, everyone.
Thank you. And thank you all who provided comment verbally and in writing. Secretary Galley, seeing the time, any last words?
No, just gratitude to everyone in the public, all the commissioners. Look forward to seeing you next week for another rich conversation. Enjoy the rest of your afternoon, everyone.